Session will start today with a session focused in the response of research, hematology research community to the COVID pandemic. And with me here, Dr. Farja Al-Qahtani. She's a professor of hematology from King Saud University. She will start to present the first speaker.
Assalamu alaikum, and it's a pleasure to introduce my colleague, Dr. Radhui Al-Faqih. He is consultant of hematology and stem cell transplant, head of research unit at King Faisal Specialist Hospital. He has more than 70 publications internationally and nationally, is well-known figure in our society or in the hematology society. Dr. Radhui Al-Faqih will introduce about the COVID in this era. Thank you.
Thank you much for having me, and glad to see everybody back into action. I think this one will advance the slides. Yes, these are my disclosures, but I don't have any commercial interest with any of these entities. So this is my agenda. I'll go over an introduction, then we'll talk about COVID and the transplant and the experience in the Ebmt area. So as you all know, the pandemic started in China in 2019, then was announced as a pandemic in March 2020 by the WHO. Here you see the number of cases accessed 2 weeks ago. So worldwide, 364 million cases confirmed, including 5 million deaths, 5.5 million deaths. So this is a huge number of deaths. And a total of 10 billion vaccine doses has been given. In Saudi Arabia, 671 cases, 671,000, so almost a million, and almost 9,000 deaths. So definitely people with transplant will be affected because we have around 90,000 transplants carried out annually. You have 1.5 million post-transplant people living in the community. So these will capture COVID, and as you know, the mortality in some subgroups was reported to be high, like patient with comorbidity, hypertension, diabetes, elderly, pulmonary disease. So because of this increased mortality in specific groups, attention was brought to this special subgroup of immunosuppressed patients, the post-transplant patients. If you go to PubMed and search for transplant and COVID, you get more than 6,000 articles. If you search for COVID and stem cell transplant, you see more than 800 articles. So this is a lot of articles during a brief period of time, which tells you that this entity is important. So this is the initial experience from Wuhan, China. As you see, the severity rate is around 40% on the down graph. And then you see upstairs the comparison between no cancer patients, cancer survivors, and a patient with active cancer. And as you see, the severity and the death rates are much higher in survivors and in patients with active cancer as compared to patients without cancer. We did a meta-analysis after a few months of the COVID. So we reported a mortality of 21.1% in cancer patients, the rate of severe disease 45%, intensive care unit admission 14.5%, mechanical ventilation around 12%, and all these numbers were much higher than non-cancer patients. Then the ASH did this collaborative COVID registry where you can go, any one of us can go and input his hematology patient with COVID. It doesn't have a large number of patients, but it's very informative. It has 1,158 patients with blood cancer and captured COVID. And as you see, they split, the death is the red and the blue is recovered, yellow is unknown status. So they did multiple subsets, as you see, per race, per age, where the infections are, age and mortality, comorbidities, smoking status. So a lot of good information can be seen there. And all in all, you see the red bar is constituting around 20-25% of the mortality. So this is much higher than the regular people. Here also you see the severity and the death rate. The death rate is 17.5% all in all, the first graph. And the severity is more than 50% have moderate to severe disease. They also report per neutrophil count upon COVID, per lymphocyte count. Symptom-wise, it doesn't differ from the normal people. So you see fever, cough, shortness of breath, and fatigue are the most commonly reported. Then they report the treatment received by these patients, and it mirrors what's given in the community for other patients: azithromycin, chloroquines, remdesivir, and high-dose steroids were the most frequently used drugs. In terms of the duration of symptoms, the median was 11 to 15 days in these people. So with this severe illness and the history of viral illnesses in transplant patients, it was expected that transplant patients will have a more severe course. Now, the first two cases reported from Wuhan, both died at 20 years old, 17 years old, both received haplo and died shortly without mounting antibodies. So it was very alarming. However, some reporting bias probably exists because you would report these cases. Maybe if you get a transplant patient who recovered, you will not report. And then the solid organ transplant fatality rate was reported to be 28%. Then other reports came about the persistently positive viral detection in patients with transplant. Whether these viruses were alive or dead, we did not know, but it was reported that these patients tend to shed the virus for a long time as compared to the others. Then other groups started to report their experience. As you see here, this is from the United States, 17.7 recipient, allo 35, auto 37, and CAR T-cell 5. The median time from cellular therapy to COVID was 782 days, so more than 2 years. Overall survival at day 30, 78%. So 22% of these patients died. This is very significant. And the number of comorbidities, presence of infiltrates, and neutropenia upon presentation correlated with worst outcome. Then another study came from another institution, 367 adult and pediatric patients, both transplant and hematology patients. And as you see, there were 58 auto, 65 allo. The others are hematology. With a median age of 64, the mortality rates in transplant patients was better actually as compared to non-transplant. So patients with active cancer do worse as patients transplanted and already beyond the transplant period. As you see, the mortality 31% in non-transplant hematology patients as compared to 17 and 18% in transplanted patients. So the mortality in these patients was driven by older age, disease status, remission or not, performance, as well as by other immune parameters like neutrophils and the level of inflammation. CIBMTR shortly after that reported their experience, 318 patients, 184 allo, 134 auto, median time 17 months for allo, 23 months for auto, median age 47 for allo, 64 auto. And as you see, half had mild disease, the others had a moderate to a severe illness. Mechanical ventilation, 14% of patients needed that. And overall survival, as you see, 68% for allo, 67% for auto. So this is around 33% death rate in this population. And they reported that male sex, age, COVID within 12 months of transplant had the higher rates of mortality among others. Lymphoma people in the auto transplant, lymphoma had more mortality, and this is probably reflecting the use of anti-CD20 in these patients and the lymphodepletion that result from that. Absolute lymphocyte count less than 0.3 at COVID was associated with worst survival as well. Now the others, race, ethnicity, comorbidity index, and immunosuppression did not correlate with the increased mortality. We did report our experience from the Gulf countries. So this is a collaborative effort. Many of you collaborated with us on that. And as you see, we collected 91 patients. The median age was 35, so much younger than what's reported from the West. Median time from transplant to COVID was around 15 months. 48 only had comorbidities, and most of them had one comorbidity, like hypertension, diabetes. So less comorbidities in our population, younger age 35. 57 allo, 43% auto. Majority were myeloablative, and the majority were in remission when they captured the COVID. So as you see, 86% had symptoms, 50% mild, and the others are moderate to severe, so reflecting the prior experience. 53% needed admission to the hospital, 31% went to ICU, 33% needed oxygen, and 10% needed mechanical ventilation. Our mortality was 4.4%. This is much lower than others, and it is assumed because of the young age and because of the low number of comorbidities. Also, possibly because the healthcare system in the Gulf area was not overwhelmed like in other countries with the big spikes of COVID. So maybe these patients were cared for in tertiary and quaternary care centers rather than the others. And as you see, the thrombosis was one patient on the acute kidney injury, 10%. Now, 66 patients had repeated PCRs, and 51% of them, 51 over 66, so 2/3 turned negative. The median time to turn negative was 37 days. So this can tell you about shedding the virus in these people. It takes longer than normal, so 37 days. About antibodies, developing antibodies, also 2/3 developed antibodies at a median of 34 days. So it was a very informative collection of patients. And here you see the impact of different factors on the outcomes, like we did the age, BMI, comorbidities, underlying disease status, all this type of risk factors, and their impact on mortality, admission, ICU admission, oxygen, mechanical ventilation. And we only found that the time from transplant to COVID is associated with worst outcome. So a time, if the patient gets COVID within 6 months of transplant, their outcome is expected to be worse. This is another meta-analysis. This was reported recently. The nice thing about it, it's a big collection of patients. So 2,000 patients with COVID, median age 57, median time to capture the infection 23 months after auto, 16 after allo. And the mortality rate was 19%. So this tells you the exact mortality rate of a transplant patient because it has a very big collection, 2,000 patients. Now, in auto, if you split it, in auto patient, it's 17%. In allo patient, it's 21%, so a little higher in allo patients. Now, how about with CAR T-cell? You know, CAR T-cell wipes out the lymphocytes, and as such, these patients don't mount antibodies. And as you see, the mortality is 41%. So way much higher mortality rate as compared to transplant patients. Now, all in all, I collected these as, you know, factors that correlate with worst outcome in cellular therapy recipients. So age, active disease, time from transplant to COVID, comorbidities, absolute lymphocyte count, ANC at COVID, immunosuppression at COVID, and CAR T-cell recipients. All these patients will have a worse outcome as compared to the others. So with that, you know, we started to modify our practice. A lot of you underwent the same in the community: physical distancing, limiting visitors, negative pressure rooms for COVID positive, special wards for COVID, physical distancing, environmental cleaning, and then the healthcare staff, daily screening, universal precautions, airborne droplet precautions, and for patient, universal screening, isolation, and telehealth for stable patients. So you all implemented all of this because of the reported higher mortality and complication rate. And then societies started to develop their guidelines on how to deal with these patients. As you see here, this is the Tct Guidelines. So patients and donors had some guidelines. For patients with positive PCR, you have to wait 2 weeks and the patient has to be asymptomatic and 2 negative PCR 24 hours apart to restart your process of transplant. Now, this is subject to exceptions because, as you know, clearing by PCR may lag behind the symptoms. So you have to balance, the risk of your patient, the urgency of transplant with the PCR results. So it's not mandatory, but it is recommended. If you have a patient in contact with COVID, okay, same applies. So 2 weeks, 2 negative PCR 24 hours apart. For donors, the virus is detected in the blood of patients. So, but the duration of viremia, how long it stays, we don't know. Transmission rate is unknown. This is a case of a patient who donated positive stem cell, okay, with no impact on the recipient. I will report a case shortly in our hospital, haplo, with positive donor. So we don't know the impact. But in general, the TCT says donor with positive PCR are not eligible to donate. And you have to clear them. You have to wait 28 days, do PCR, and make sure they're asymptomatic before you clear them. If possible, ensure alternative source is available. And during the 28 days before donation, these donors are taught about hygiene and practices to avoid COVID. Cryopreservation is recommended for donors, and we started to do that in our hospital with the COVID spikes. Now we're doing that with the Omicron. But for unrelated donors, this is like a relative contraindication to freeze the cells of the unrelated donor, because what if you don't use them later on? This is, and as you know, the donor safety is a priority for registries. So this is problematic when you use unrelated patients. So this is a few cases just to give you the flavor of disruption that happens. This is a 21 years old CML transformed to ALL, planned for haplo. So haplo, we do bone marrow collection. This is our program, okay? And his father, who is the donor, became febrile day 0, PCR positive. So we postponed the transplant one day, trying to find another haplo. His sister, who is another haplo, was febrile as well. So we did proceed with the donor. We used peripheral blood because the operating theater was not available for shortages and people infected. And day 5, the patient turns out PCR positive. We had to transfer him to a COVID ward. So there, the nurses are not transplant. This is a haplo high-risk transplant. Nurses are non-transplant. The MDs are non-transplant in that ward. We had to test all our transplant ward, all the patients, sitters and staff, and any new neutropenic fever during that time we had to test for COVID. So very disruptive. He was treated, and gladly he turned around, he engrafted, and he's still alive, alhamdulillah. So, but he received tocilizumab twice, and he developed macrophage activation syndrome around the time of engraftment. He needed IVIG, DEXA, and ruxolitinib. Eventually, his PCR became negative. This is another case, 44 years old, diffuse large, relapse in the CNS, so high-risk relapse. 2 cycles of methotrexate RSE responded, 3rd cycle with collection, fever, PCR positive. Okay, so this is day 12 when you want to collect. So we did the apheresis in the COVID ward, despite a lot of resistance. Gladly, the line was placed before admission because line placement was very problematic during that period as well. She collected, PCR was done on the collection, and it was negative, and converted back quickly to negative so she can be admitted in the transplant ward. She's transplanted, she's still alive, disease-free, alhamdulillah. 21 days from the first PCR positive. Now, this is a case, unfortunate patient. So 67, diffuse large B-cell lymphoma, relapse, salvage, then PCR positive after 2nd cycle, so before collection. Admitted with COVID-B, recovered, persistently positive PCR and negative antibodies. So he was due for mobilization, denied access to the main hospital, denied line placement because his persistently positive PCR did not develop antibodies. So we had to admit him to the COVID ward after recovery, place a line, mobilize him, collect, despite being persistently positive, also denied to transplant ward. So we have to transplant him now. He's collected, everything is ready, but he's still PCR positive. They denied his admission to the transplant ward and delayed, eventually became negative, admitted. Day 2 of BEAM, he developed hoarseness. So workup showed increase in the size of mediastinal nodes. So he got auto-transplant while progressing. He's in remission now. Unfortunately, last month he developed AML, therapy-related AML. But he's in remission from his disease, and he survived all of this. So basically, very disruptive state. Staff shortage, physicians, nursing, patients testing positive, many staff working extended hours. So we decided to stop transplant for hemoglobinopathies, myeloma, and any non-urgent transplant, we did delay it. General hospital precautions, of course, this applies to all hospitals, restricting entry, screening all staff, no visitors. And for donors and patients, PCR has to be done 1 day before any procedure. We did peripheral blood for all our patients during that period, and now we're back to the same practice. So even for haplo, we are cryopreserving now. And we limited the caretakers, to one patient with no alternation. So, allotransplant, they'll stay for 90 days in Riyadh, and we allowed only one patient, one caregiver. Patient with terminal conditions inside the hospital were problematic. Families want to see them, to visit them, and we couldn't. And all of this was done in complex logistics, lockdown, travel restriction. At one point, we didn't have personal protective equipment. We were short of gowns and masks. Plus, testing kits were low, and all these new PCR methods had to be validated. So it was a pretty stressful situation. Now, all these restrictions were reflected in this paper, which will come out soon. So this is the Ebmt activity survey. This is done yearly since 1990. So since 1990, the Ebmt reports their transplant activity, and it has been going up and up all this time for 30 years. The first time it dips was 2020. So all these restrictions were reflected in this activity with a decrease in the allo and auto-transplantation. There was an increase in CAR T-cell activity in that survey, and this is probably because this is a new therapy and people are adopting this new therapy. So in transplant patients, there was a decrease in allo for non-malignant disease, like what happened in our practice, decrease in auto for autoimmune disease. These were statistically significant. Now, the more interesting thing, cord blood started to rise for the first time since 2012. And this is because MUDs were not available during this period. There was a severe shortage in MUDs because of the logistics, lockdowns, and the infection. Haplo as well, the use of haplo increased as compared to MUDs. So the Ebmt issued this regarding vaccination. And as you see, they recommend vaccination starting 3 months post-transplant if the rate of infection is high in the community. I do it earlier if the rate is high. So basically, if the patient doesn't benefit, fine, but at least you offer some protection. And they made some exclusion, like patient with GVHD, patient with recent CD20 antibodies, CAR T-cell patient with aplasia, ATGUs, and the children. But these are guidelines, they are not mandatory. And they say in that survey that, one more slide. Healthcare workers should be vaccinated to protect patients. Household contacts should be vaccination. And they said the positive antibody test doesn't mean protection. We don't know what's the protective titer. Duration of protection is unknown. So this is a report of vaccinated transplant patient from France. All received Pfizer, 687 patients. And as you see, the split between MUD, matched sibling, and haplo. And what they said, they found that early vaccination is associated with non-response, and that's basically transplant within 12 months and then vaccination. And people who received rituximab in the last 6 months did not respond well. Auto response was higher than allo, 90% responded versus 80%, but the magnitude was higher in allo. Calcineurin decreased the rate of response, as you see, 56% on immunosuppression responded. CAR T-cell patient, we have 3 small studies, and as you see, the rate of response, 36, 21, 21%, so pretty low, and because these patients have wiped out lymphocytes, so they can develop antibodies. Patient perception, this is a study, how did the patient feel? And basically, there was no difference from pre-transplant, post-transplant, from pre-COVID, post-COVID in terms of depression, anxiety. I don't know if this is a cultural difference. I bet if this is done here, it'll show difference. So a lot of unanswered questions still. What's the aspergillus rate with these COVID? COVID outcomes per COVID variant in transplant patient, we don't know. Outcome of vaccinated patients, so transplant vaccinated, what's their outcome? Protective titers, different vaccines results, we only have Pfizer. And the antibody-based therapy now is becoming popular, so we don't know its efficacy after the vaccination and its need, it's very expensive. COVID and graft versus host disease, does it increase it, decrease it, worsen the severity? We don't know. Interplay with other viruses. Transfusion from unknown status of the donors. We don't screen donors, you know, when we transfuse, and all our patients receive transfusion. Do you vaccinate if the patient was vaccinated before transplant? We don't know. And whether these recovered patients are at increased risk for post-transplant cardiopulmonary complication and other complications, we don't know. So in summary, very disruptive. Every single aspect was affected: recipient, donor, harvest, staff availability, drug interaction, GVHD, and diagnostic challenges. And as you know, these patients are diverse and in variable states of immunosuppression, so the outcome will be different. It's a new disease, a lot of anxiety with the new, and an ounce of prevention is worth a pound of cure. Now, vaccines, it seems that the mRNA vaccines are safe in immunocompromised according to CDC and recommended for everybody. With that, I'll finish, and thank you. Questions at the end?
Thank you, Dr. Riyad, for the elegant presentation. We will leave the questions until the end. Now it is my pleasure to introduce the next speaker, Dr. Abdurrahman Raiza. He's a consultant hematology at the Department of Oncology in National Guard in Riyadh. He's specialized in thrombosis, and he's leading the thrombosis program at the National Guard Riyadh. He will present the thrombosis in the setting of COVID-19 infection, data from Saudi Arabia.
Thank you, Dr. Badr. Thank you, organizing committee, for the kind invitation. I will talk today about our experience in COVID and thrombosis. So since the beginning of the pandemic, more than 300 million have been infected with coronavirus, with more than 5 million deaths worldwide. And several observational studies have been conducted, and what have been noticed that there is an increased risk of thrombosis in this patient. In some studies, up to 60% in the ICU patient, they will have thrombosis, but also in the ward patient, which seems to be higher than the matched ward patient. Coronavirus may infect directly the lung parenchymal endothelial cells, which ultimately will lead to ARDS. And at the end, some patients will have macrothrombi in the form of pulmonary emboli. It seems also that they have a distinctive coagulopathy feature, different than the usual DIC in the form of near normal APTT or BT compared to the non-COVID patient, because of the reported case of increased thrombosis risk and the fact that ethnicity may have a role in the incidence of thrombosis. We thought of looking to our population to the risk of thrombosis and bleeding. So we conducted a retrospective study in 4 centers in Saudi Arabia. We included all patients who have been admitted in these hospitals, and we excluded patients who have been transferred from one hospital to another hospital or admission less than 24 hours. So the primary outcome is the rate of venous thromboembolism, defined as the pulmonary embolism or deep venous thrombosis, upper or lower, and unusual site thrombi, conferred by appropriate imaging. We included also highly suspected pulmonary embolism based on the treating physician, based on combination of clinical plus laboratory, because of the difficulty of obtaining sometimes the imaging in these patients because of the risk of infection or because of the patient situation. And there was no screening ultrasound in this patient. We looked at the secondary outcome, which is arterial event defined as cerebrovascular accident, mesenteric ischemia, limb ischemia, or myocardial infarction, diagnosed based on combination of the laboratory plus ECG plus the clinical background, composite event, venous and arterial, and bleeding event stratified by the definition of proposed by ISTH. So after exclusion, 530 patients non-ICU and 106 ICU patients were included in the study. And if you look at the baseline characteristics, ICU patients were more older, more male patients in the ICU, and they have more weight and more comorbidities in the ICU patient compared to the non-ICU. And this is regarding the anticoagulation treatment that have been received. Almost all patients received pharmacological prophylaxis, with the most commonly used is enoxaparin 40 milligram once daily, and up to 16% in the ICU received the BID dose of enoxaparin. And almost 8% of the ICU patients received full dose anticoagulation for various reasons. So the primary outcome, which is the rate of VTE, 12 patients developed venous thromboembolic event with a rate of less than 1% in the non-ICU versus 10% in the ICU. Most of these patients develop this venous thromboemboli while they are on usual standard dose of DVT prophylaxis. These are the VTE characteristics. Most of these were pulmonary emboli with some deep venous thrombosis. One patient in the ward developed a mesenteric vein thrombosis. We looked to the predictors of venous thromboembolic event and composite outcome, and from the selected predictors, the only risk factor is the baseline D dimer, defined as the first D dimer from the admission. So what does it mean having a VTE rate of almost 10% in the ICU? If we look to the published studies, a highly variable rate have been reported, which could reach up to 80% in some studies. And if we look to the non-COVID, it's approximately 10% of the non-COVID patients admitted to ICU will have a venous thromboembolic event, which is similar to our study. So why there is a highly variable rate reported in these studies? First, in the studies who did the screening for ultrasound, the more you look, more likely you will find a thrombi. Ward versus ICU patient, the design of the study, because probably of missed cases in the retrospective studies, lower rate have been reported. Probably the ethnicity have a role, and the clinical practice changes between the countries and between each hospital may have a role. In our population, the reason for this rate, probably because of the early pandemic. I remember that we are admitting even mild cases during the early pandemic, may have a role. The median age in our study was lower. Different definition of thrombotic outcome and different prophylaxis regimen. All of our patients, almost all of them received pharmacological prophylaxis. There was no screening for thrombotic event like ultrasound in our hospital. Ethnicity may have a role. One of the important causes why this rate in our hospital, maybe we are missing some cases. It has been reported that up to 60% in the postmortem studies have died unexpectedly secondary to pulmonary embolism. And it's very difficult to diagnose a BE-related mortality without an autopsy. That's why major societies like ISTH have proposed definition to standardize the BE-related mortality. So regarding the arterial events, up to 8% in the ICU patient develop an arterial event compared to less than 1% in the non-ICU. Most of these events were cerebrovascular accident, but surprisingly, some patients in the ward, they develop also cerebrovascular accident. There is no good explanation apart from this is a prothrombotic condition. Regarding the bleeding, up to 9% in the ICU develop an overall bleeding. Most of these bleeding were non-major, and less than 1% develop a bleeding in the non-ICU. And there is also a widely variable rate reported the bleeding in the COVID-19, but it seems that our rate is higher than the non-COVID. It's expected to be 5 or 6% in the non-COVID patient, and our ICU patient develop up to 10% bleeding risk. We did another study, compared the MERS-CoV versus the COVID-19, looking to the thrombosis and the bleeding risk in these patients, because almost 50% similarity between the two in the genome scan. Not only the genome scan, but there is a similarity between the two viruses regarding the clinical background. So we conducted a retrospective study, included all ICU patients in the MERS-CoV compared to COVID-19. All of them were an ICU admitted in these 4 hospitals. And if we look to the only 58 we got in the MERS-CoV versus 234 ICU COVID patients. And the COVID-19 were older, more comorbidities in the COVID-19 compared to the MERS-CoV. So if we look to the outcomes, it seems that COVID-19 have a higher risk of venous thromboembolic event compared to the MERS-CoV. And the opposite is true for the arterial event, more arterial events compared to the, in the MERS-CoV compared to the COVID-19, with probably similar rate of bleeding, and at the end, similar rate of composite event, venous and arterial. This may hint that not only the COVID-19 is the thrombotic condition, but probably MERS-CoV as well, but it needs to be confirmed in a larger study. So what can we get from these studies? I think it's very important to know what are the updates for the anticoagulation use in this in the COVID-19. Since we published our study, several RCTs have been conducted looking at different doses of anticoagulation, trying to answer, is there any role for anticoagulation in this patient, not only to decrease the thrombosis risk, but to change their outcome. As we know that from the animal models, maybe there is a role for antiviral or anti-inflammatory effect of the heparin. Or just maybe we are overdiagnosed, we are overlooking the venous thromboembolic event. So for the ICU patient, 2 RCTs have been published so far. The largest is the multi-platform RCT, combining 3 RCTs together. They randomized patient, more than 1,000 patients to therapeutic dose versus the usual care or the usual DVT prophylaxis, prophylaxis or intermediate dose, and their primary outcomes, the composite of 21 days, organ support-free days, not requiring any of these support, plus the in-hospital mortality. The second one is the inspiration study done in Iran. They randomized patient with prophylactic versus intermediate dose, and they looked to another different primary outcome. So the first one, the largest one, is the multi-platform. It was stopped early because it reached the pre-specified inferiority margin, and there is a higher risk of fatality in patients who have been randomized to therapeutic dose anticoagulation. In the inspiration, again, it's a negative study for the primary outcome, and also there is no difference in the secondary outcome. This leads the ASH guidelines that have been published recently to recommend against using full dose anticoagulation in these patients, in the ICU patient. So for the non-ICU patient, the scenario is a little bit different. 3 RCTs have been published so far. Again, the multi-platform, the included patient, ward patient, more than 2,000 patients, therapeutic versus prophylactic or intermediate. The other one is the rapid trial, randomized patient therapeutic versus prophylaxis, but they have an inclusion criteria if the patient is having high D-dimer more than upper limit of normal, or oxygen less than 93% of room air, or D-dimer more than 2 times upper limit of normal. The Hep COVID, again, randomized the patient therapeutic versus prophylaxis with different inclusion criteria, D-dimer more than 4 times upper limit of normal. So if we look to the primary outcome in the multi-platform, there is an increased probability of being organ support free by an absolute number of 4% only, from 76 to 80%. In the rapid trial, their primary outcome, they looked to a different outcome, which is death, invasive mechanical ventilation, and invasive mechanical ventilation or ICU admission. There was no difference in the primary outcome, but there is, in the secondary outcome, there is the full dose decreased the risk of death from any cause from 6.7 to 1.8. And I think it's because it's secondary outcomes, just a hypothesis-generating idea. The last one is the Hep COVID trial. They looked to another primary outcome, which is VTE, arterial or death from any cause at day 28. And there is a significant difference between the two arms in favor of full dose anticoagulation, 41 versus 28 days, mainly driven by the decrease in venous thromboembolic event and not the other outcome. So this is the draft recommendation from the ASH that was made public for public comment, just released a few weeks back, and they recommend against you. They suggest to use full dose anticoagulation in patients who have been admitted in ward. And this is the NIH National Institute of Hospital. They also suggest to use full dose anticoagulation in patients who have been admitted to the ward, and they recommend against full dose in ICU patient. So before considering starting full dose anticoagulation in ward patient, I think it's very important to know the bleeding complication in this patient. So this is the ICU patient in the interventional arm. The full dose anticoagulation, they have a major bleeding ranging from 2 to 3%, which is similar to our major bleeding in the ICU. But remember, our ICU, they did not, very few patients receive the full dose anticoagulation. It means that despite that they are on full dose anticoagulation, they bleed 2 to 3%. They are highly selective patients. In the ward patient, they have a risk of 1 to 2% major bleeding if you will prescribe the full dose anticoagulation. And then remember, they are very selected patient. Last thing about the post-discharge thrombosis risk, it's widely variable rate have been reported. Again, it seems that for the unselected patient, it seems low and comparable to the non-COVID patient, but for the selected patient, it may be higher than the non-COVID. The largest prospective study that have been done is the Coronary Registry. Their 90 days post-discharge VTE is 1.5%, which is slightly higher than the non-COVID patient. They look to the predictors for post-discharge VTE risk, but they are only risk factors, and there is no currently prospective validation tool to predict the post-discharge venous thromboembolic event. This is the only RCTs that have been published so far regarding the post-discharge VTE. Michelle studied the randomized patient rivaroxaban 10 mg versus placebo for 35 days, but they included the patient who have a high risk, defined as improved risk score 2 to 3 plus high D-dimer or improved more than 4, and they look to the composite of venous or arterial thromboembolic event. And there is significant difference between the two in favor of discharging the patient to rivaroxaban post-discharge. ASH have published their recommendation, and they suggest against post-discharge prophylaxis, but they made remarks regarding this recommendation that an individualized assessment of patient risk of thrombosis and bleeding is very important. So in conclusion, VTE rate in hospitalized patients with COVID may not be higher than expected, but we found a higher rate of arterial and bleeding event, and an elevated D-dimer could predict a thrombotic complication in COVID-19 patient. Some areas requiring further investigation. First, we need to know the accurate estimate of risk of thrombosis and bleeding and the predictors and the best ways to do it in prospective study with the adjudication of the event. Again, can we rule out BE or DVT using a prediction model plus D-dimer without the need for imaging? Another question is, can we implement the full dose and calculation outward patient or not? Will they get benefit? Will they get bleed more? Other question is the risk of and predictive thrombosis and bleeding post-discharge. All of this needs to be the best ways to do it in prospective observation or intervention study. And at the end, I would like to thank our colleague who contributed to our work. Thank you so much.
Thank you, Dr. Abdurrahman. It's my own pleasure to present Dr. Fehna Rogi. He is a pediatrician, specialized, he did his clinical allergy and immunology fellowship in Boston Children's Hospital and bone marrow transplantation from Dana-Farber Cancer Institute at Harvard Medical School. And Dr. Rogi is mainly interested in basic science and research. It's a pleasure to introduce him today. Thank you.
Thank you. Assalamu alaikum. Sabah al-khair. I would like to thank the organizing committee for inviting me to give this talk about the antibody response after vaccinations. I think this is a fascinating topic, and today we'll try to answer a lot of questions for immune-compromised patient and also for immune-competent patient, but we'll start with some baseline. Okay, I didn't have anything to disclose today, and all the work is funded by KMark. Some of them published, some of them submitted already. So we'll start with the introduction, then I'll talk about the type of the vaccine for SARS-CoV-2. And also then I'll talk about the immune response to SARS-CoV-2 vaccine, the normal immune response. Then we'll go for some of the international data for immune response for both immune-competent and also immune-compromised patient. I think the most important for this presentation, we need to talk about our data in Saudi Arabia. And the question for me, is Saudi Arabia almost like other country? We said initially no, maybe because we are the endemic area for MERS-CoV, and according to Dr. Abdurrahman, the genetic almost for MERS-CoV and COVID-19 almost the same, like 50 to 60% similarity. Maybe our antibodies data is different from the other international data, and this is the beauty of this talk. So we'll talk about introductions. SARS-CoV-2 virus cause COVID-19 infections and causing ongoing infection due to a lot of variants nowadays. And this pandemic highlights the importance of producing effective, this is the most important, effective and safe vaccines against this virus. But not only against this virus, against all variants of the virus. And this is the most important things we need to answer also. All vaccines work differently to introduce antigen. This is the most important with all vaccines. You need to introduce an antigen, and this antigen, the immune system will produce a memory cells, either the T memory or B memory cells. So this is now the most important. You need to ask how many generations of the vaccines. So we have the old generations, which is the inactivated virus or inactivated bacteria and live attenuated. This is the first generation produced for vaccinations. And then there are some improvement to the second generation vaccine. And the second generation vaccine, like the protein subunit, like for example, hepatitis B vaccinations, or vector-based vaccination. Then nowadays we have the third generation of the vaccinations with the genetic material like DNA or mRNA vaccines. So this is the trajectory for all vaccinations, from whole virus, either attenuated or killed, to the part of the virus, now to the genetic material, and our body will produce those genetic material. And this is like overall data for all vaccinations. So what about the COVID-19 vaccinations? What we have, COVID-19 vaccinations, we have inactivated whole virus like Sinovac, and there is a now platform for Sinovac starting with inactivated virus. And we have also viral vector. And the most important, as immunologist, I need to ask simple question. Is this vector replicating or non-replicating vector? So replicating factor, that means this maybe multiply and maybe affecting some immune-compromised patient, but non-replicating factor like adenovirus. This is the most important, and this is all the COVID-19 vaccinations is non-replicating factor, either like Hazentra or Johnson & Johnson, and depend on the factor, adenovirus. Is it the adenovirus taken like from animals like chimpanzee, like AstraZeneca, or from a human like the Russian vaccination? Then we'll come after the factor, the protein subunit. We have also Novavax. It's now in a lot of clinical trials. They are taking some protein from the virus and they're producing the immune system protections. We have the DNA virus, the in vivo, which is now in the animal studies, coming to the human nearly. But we have the RNA viruses, the messenger RNA viruses. We have two, like Pfizer or Moderna. And for all these vaccinations, the second question for me as an immunologist, whatever you used, either the whole virus or a protein or genetic materials, what added? Is there any adjuvant or just only nanoparticle like lipid nanoparticle? So the adjuvant, most of the viruses, they have adjuvant, like Pfizer, Moderna, they have just only the lipid nanoparticles. So this is like general, how many vaccinations we have for COVID-19. But the most important for me as an immunologist, how the immune system react to vaccination. This is the most important. So let's now assume what we have in Saudi Arabia here. We have two types of vaccinations. We have mRNA vaccinations, either Pfizer or Moderna. And we have the second type, the adenovirus vector, the AstraZeneca. So here you can see mRNA viruses. This is immediately, you give the injection. After giving the injections, the dendritic cell will take all the material, the nanoparticles, the lipid nanoparticles, and also the genetic materials producing the spike protein, S1 protein. And then immediately, sensing those material, the question immediately, is it DNA or RNA? If this is DNA, RNA, this is immediately will sense by toll-like receptor 7 and the MDA5, and those immediately start to produce the cytokine storm. So immediately after vaccination, the immune system, the innate immunity, producing interferons, signatures, and also other cytokines and chemokines. Those important will activate the dendritic cells. Activated dendritic cells will present this protein to the T cells, which is here. Present all to the T cells, and the T cells will be activated, and then after that, the T cells will produce different reactions. What reactions? Produce T helper cells, which called TFH. And those T follicular helper cells help the B cells to produce antibodies. So this is important things. One is T cells helping the B cell to produce antibody. So what about our patient if they have using steroid? If we are using chemotherapy, if we are using a lot of medications suppressing the T cells, what about these reactions? And the second issue is the T cells immediately produce multiple T cells, including augmenting the CD8 cytotoxicity and also augmenting the T helper memory cells. So we have here augmenting antibodies response called the humoral immunity, and also augmenting the T cells response, which is called the cellular immunity. What about if you take adenovirus vector like AstraZeneca? Adenovirus is a DNA virus. So immediately will be taken by the dendritic cells. So what's the material? DNA. Adenovirus is a DNA virus. So this is sensing by different receptors. TLR9, then we'll start the pathway almost the same. So after understanding this, the human response to the vaccination, so we have a humoral response, which is antibodies productions, and we have a cellular response, which is dependent on the T cells. This is the most important two response. So in this talk, we try to measure everything, humoral response, cellular response, but I will not talk about all the response because this will take longer durations. Today, what we'll talk about we'll touch only about the humoral response and the vaccine response for antibodies productions. So where do we stand in Saudi Arabia? Before that, let's see how the worldwide or international data looks like. So this is the initial international data. So you have the after called naive and post-COVID-19. So the patient is naive, doesn't have or didn't have any infection. He received the vaccinations, which is the white, dose 1. Immediately, he has good response. If he received the second dose, he has also another excellent response increasing after that. But if the patient has infection and he received first dose, you can see here, this is infected, the black dot, infected, and after the infections and receiving the first dose, almost similar to the people taking 2 doses. So if you give infections, first dose, second dose, the response is continue the same high. So now we know after the first dose, the response is very high, but after giving the second dose, the IgG response is more higher after the second dose. So then we know now the response for antibodies is clear. It's clear around 90% after the first and increasing to 95 after the second dosing. So what about the patient with autoimmune disease and immunosuppressive medications? Are the same or not? So you have here, this is the baseline, all the patient from rheumatology group, they don't have any infections before because the antibodies is negative. After the first dose, there is response, but really the response is not like the response for the normal. It's around 50% the response. But then, after the second dose, the response is increasing dramatically. So the immune-compromised patient, they respond to the first dose partially, but the second dose, the response is excellent. Now, I would like to introduce a concept. The concept is saying, I know all the people, they are counting first dose, second dose, third dose, fourth dose. This is not the usual immunologist counting about the dosing. So what we have, the primary vaccination. So the primary vaccinations, until the patient have the optimum effect, which is 2 doses of Pfizer, 2 doses of AstraZeneca. But what about the immune-compromised patient if they don't have excellent effect? So we need to add another dose, which is called the third dose, but this is not booster. This is called all primary response to have the optimal effect. Then you will count after that the booster. So primary immunity after vaccinations can be 2 for normal people, but maybe 3 vaccination for some immune-compromised patient. And then, okay. Can you go back, please? Also back. Okay, so you see the response, but the most important thing after that, what we are measuring here, humoral immune response. So what about the patient if they are using anti-CD20, like rituximab or the other anti-CD20? We, after that, stratified the data, the red patient and the blue and the black patient. The black patient, they are using immunosuppressive medications. They are not B-cell depleted. The red one, they are with normal B cells. So you can see the response after rituximab or B-cell depleted medications is lower than the other immunosuppressive medication. So concept from that, first of all, healthy, they have excellent response. Immune compromised, also good response after the second dosing. And then if you have B-cell depleted medication like rituximab, this will decrease the response. Then if you would like to go to more like for cancer patient, for cancer patient, you can see this is from New England, from the cancer, from the cell. You can see the control, they have excellent response. You have the patient with the tumors, they have poor response. If you divide them to the solid tumor or hematological tumor, always the hematological tumors, the response is more slower. So now we have concept now, the response in immune-compromised patient is partial, but this is worse in patient with hematological malignancies. If you can compare the most important, what's the best for immune-compromised patient? Is it Pfizer, Moderna, AstraZeneca? So can I ask a question? Would you like to give your post-BMT patient Pfizer, you can raise hand, or AstraZeneca? Let's see how many persons would like to advise for just only giving post-BMT or immune-compromised patient Pfizer vaccinations. Can you raise hand? AstraZeneca? Both? Okay, I can say most of the people, they would like to give only Pfizer. So let's see what the data about Pfizer and AstraZeneca. So this is like the Cell paper, but we need to address something in this paper. They compare only 1 dose of AstraZeneca to 2 doses Pfizer or Moderna. And this is maybe it's not equal, because you need to compare 2 to 2 to 2. You can see the response in AstraZeneca is good, partial, but the Moderna and Pfizer is good. But this data, if you read it carefully, they measure only first dose of AstraZeneca to 2 doses Pfizer and 2 doses Moderna. So let's go now to you receive the vaccinations right now. After like few months, how much your immunity you have, like humoral immunity. This is depend, you need to ask the immunologist or the pathologist or the scientist measuring the antibodies, what he's using antibodies. Because we can use the anti-nucleic capsid antibodies, will wane immediately within 3 months. It's useless. And if they can use the receptor binding domain, anti-RBD, this is wane within 5 to 6 months. They can use the spike protein, S1, can wane up to 9 in 1 year. So this is based on the RBD. You can see after 6 months, most of the antibodies waning. So we need, whatever we get good immunity, it's not enough. If you're measuring the RBD antibodies, and 50% of those immunity is waning within 5 to 6 months based on the RBD testing. So I think the most important now, if you would like to discuss our data, the most important as a scientist, I need to ask multiple questions, and I need to put like primary objective and the secondary objective. So the most important, you will ask me one question, is your test is valid? What's the data for validity of your testing? The second, what's the impact of being MERS-CoV endemic area on our result? Do we have false positive due to MERS-CoV or not? And the second, what about the human response of healthy individuals? Then we'll go to the immune-compromised patient. Then I ask myself one question. If you are following somebody post-stem cell transplantation, what's the impact of GVHD? If the GVHD is increasing or not increasing, decreasing, we need to look for all this data. So let's start. So we use EuroImmune, the ImmunoCAP, and this is for IgG spike 1. So I took immediately 25 patients with PCR positive. All of them turned to be positive with our testing. Then we took already another 5 patients with negative. It's negative. So specificity and sensitivity is excellent. But then we'll take it in advance. I measure it for 400 healthcare workers, healthy people, and I would like to see how much this is correlate with the PCR during the symptomatic or no symptomatic. So here, with negative PCR, most of our patients is seronegative. So it's excellent. And if the PCR is positive, most of our antibodies is positive. And for those people that didn't do any PCR, most likely asymptomatic or mild disease, also negative. So this data indicating if the PCR is positive, our antibodies is excellent, positive, 90%. If the PCR is negative, our antibodies is negative, more than 87%. And also, for those they didn't do any PCRs, mostly the result is negative. So this is really, it's good as initial validity. We talk like positive group, negative group, and then we measure 400 healthcare workers, and we see after that the validity. So this is now the second validity. If you are symptomatic, we know the antibodies titer. Okay, if you are not symptomatic, most likely the antibodies titer is very low. Okay, so this is the most important thing because most of the PCR will not done for a symptomatic patient. They will be done only for symptomatic patient. So if you're symptomatic, okay, let's use this. If you are symptomatic, the antibodies titer is more higher than if you are asymptomatic, and this is important. And then always a question coming to me is, I have COVID-19 or a flu. Then I was interested in this. I would like to see the correlation between the positive antibodies and the symptoms. What's the most predictive symptoms for COVID-19? And I calculated all. We found severe body ache is more predictive for patients with very high titers. And then after that, loss of smell and taste. Cough, fever, shortness of breath, headache. I know some of the physicians nowadays, he said, if you have very high fevers, this is most likely COVID-19. No, I think this is like predictive value. If you have more body ache, more loss of smells, this is most likely indicating COVID-19 more than the others flu. Then the questions coming, what about your data for MERS-CoV? We measure 400 healthcare workers for also MERS-CoV. We didn't find any positive except 4. And those 4s, maybe it's real, it's low titer, maybe real, maybe false positive. So I need to do neutralization assay by pseudovirus. So we did neutralization assay, all of them not neutralizing. So real, Saudi Arabia, even be an endemic area for MERS-CoV, this is not impacting our data. So our data almost looks like the others. We didn't have any positive group. So you ask me questions. You measured people not symptomatic or not infected by MERS-CoV. We took all high-risk healthcare workers, ID physicians, ICU physician, respiratory therapist, nurses in infectious disease. We collect all the high risk, and those high risk worked immediately also in the era of MERS-CoV. We didn't find any positive. Despite that, some of them, they had infections before, but also the antibodies is negative. So our data valid. What we used, like testing, valid. But let's see now the most important questions coming to me as immunologist. All my family, all my friends ask me one question. Should I go for Pfizer or Moderna, or would you like to go for AstraZeneca? And all the people in the social media nowadays giving advice wrongly. And they are giving a lot of advice. So I measured the immune response in all these. After the first dose, Pfizer. After the first dose, AstraZeneca. After the second dose, Pfizer. After the second dose, AstraZeneca. And after the infections. I would like to compare the antibodies between all of them. You can see almost the same. Blacks, the worst is the infections. So vaccinations giving you excellent antibody titers, even more than the infections. And then the second question, what about if I mix? Taking Pfizer, AstraZeneca, Pfizer, AstraZeneca, or AstraZeneca, there is no difference. So the immune response, there is not different totally in immune competent patient depending on the vaccines. Then after that, you will ask me another questions about what about the waning of antibodies? So we measured it for 9 months. This is for Pfizer. You can see it's decreasing over time. You can see here. And for AstraZeneca, we didn't have a lot of data. But with COVID infections, you can see the decrement is more than the Pfizer. And then after that, increase about reinfected. So some patient after COVID-19 infections reinfected again, and the antibodies titer is increasing. So really the vaccination is working, and we need a booster dosing for vaccination to keep these antibodies.
2 minutes.
Yeah. Then the second question about all immune compromised patient, I took all the immune biological agent. I took sickler patient on hydroxyurea. They have excellent response. And all these are immune biological agent or immunosuppressive medication. The response is some of them good, some of them partial. But then I would like to go now to concentrate about post-BMT. So post-BMT, we collected around 89 post-BMT patients. I would like to see the response between, we didn't have a lot of AstraZeneca. I found most of the patients advised by the physician to take Pfizer. For post-BMT patient, this is one. For that reason, our data and also the previous data international, they are not good in AstraZeneca with post-BMT patient, but really, there is no difference between malignant or non-malignant indications or diagnosis for those going for bone marrow transplantations, because they're doing transplant for malignant and non-malignant. There is no difference in Pfizer. And if you're coming to the second dose, there is no difference between Pfizer and Pfizer or AstraZeneca between malignant and non-malignant. So now, post-BMT patient, they need to take vaccinations. Excellent response for both BMT patients, regardless of the diagnosis, malignant or non-malignant. Then we'll come, if you are doing autologous BMT, or doing autologous transplantations, or doing allogenic stem cell transplantation, there is also in the first dosing, there is no difference at all between Pfizer or AstraZeneca. Then I said, okay, let's forget about allogenic or autogenic, or malignant or non-malignant. Let's divide the patient. Some of the both stem cell transplant, they are not on any medications. So we divided the patient to none, they are not receiving any medications, or they are on the typical GVHD prophylaxis or other biological agent. Really, there is no major difference, especially in the second vaccinations. So the response in the initial with the biological agent, it's expected as immunosuppressive medications, is less after the first dose, but the second dose is excellent. So whatever your patient is taking, please give immediately the second dosing for those patients, especially on immunosuppressive medications. So lastly, I would like to see the GVHD. So over 89, we found like 10, they have GVHD, acute GVHD. Most of them resolve without any issues. And for chronic GVHD, we have 6 patients, 1 resolve before the vaccinations, and 1 patient developed GVHD after vaccination. But if you look for like 89 patients, 1 only developed GVHD after the vaccination, this is totally non-significant. So by conclusion now, the available SARS-CoV-2 vaccines in Saudi Arabia are giving excellent human response, all of them. And AstraZeneca, Pfizer, Moderna, waning of a humoral response after native infection looks more faster compared to the response post-vaccination. There is no clear recommendation for any specific vaccine, and this is the most important things we need to advise. The immune response for immune competent looks stronger than immune compromised patient, that is stating the importance of boosting dose in immune compromised patient. The most important, if you say there is no difference in the vaccine, we are measuring what? The primary response, which is the primary vaccinations. But there are some concerns about giving the booster with AstraZeneca. The initial data is excellent. Why people is concerning about the booster dose with AstraZeneca? Because any vaccination with vector, they're afraid from anti-vector immunity. So we are destroying the adenovirus before taking this material to the immune system. Up to now, there is no data about the AstraZeneca for the first booster, but maybe the future, we need to follow it. But Pfizer is the best, and mRNA vaccines in general is the best for boostering. And this is what we are doing now in Saudi Arabia. And finally, there is no observed increased risk for GVHD status post-vaccination. Thank you for following me.
Thank you, Dr. Fehna, for the excellent presentation. Now I'd like to ask the speakers to come to the stage for, we'll take some questions. Probably we have like 5 minutes or so, then we'll go for a break.
Okay, thank you, Dr. Fehna. If the audience has any question, so I will start asking Dr. Fehna. Thank you a lot for your presentation. You answered a lot of questions. So my question for you, I'm a hematologist, and before the chemotherapy, when I will give the third vaccine for my patient, would it affect their immunity before chemotherapy, or I will delay the chemotherapy for 1 week after the vaccination, or I'll just give him the vaccine and give him the chemotherapy?
It's really very difficult question to be answered because not studied, but what's the concept of the vaccinations? So we're giving the vaccines, will be taken by antigen-presenting cells, which are dendritic cells, will produce it to the T cells to produce all the reactions. If you follow the vaccinations, like within 1 to 2 weeks, immediately with very intense chemotherapy, you're ablating most of the T cells and suppressing all the T cells and the B cells. So always as immunologists, we said, if you would like to give the chemotherapy immediately, try to give the vaccines slightly earlier to give the immune system to work, at least like 14 days for the immune system to mount the vaccination's effect and to produce the antibodies and the memory and the B and T cells. This is just only from the basic immunology, like understanding of the basic immunology, but really nobody is measuring those patients receiving chemotherapy immediately after vaccination. But all the immunologists worldwide, they are answering these questions by just only the fundamental basic understanding of vaccinations. So give it earlier.
Okay. Second question, Dr. Fehna, regarding your study, you compare MERS-CoV and SARS, the COVID, the antibodies. This is done later on after MERS-CoV, right? Or at the MERS-CoV site?
Again, could you repeat the question?
The MERS-CoV, you found the antibodies is not there compared to COVID.
Yeah.
But this is done after years of MERS-CoV, right?
Yeah. So the initial data from Saudi Arabia, all the MERS-CoV antibodies, they last for severe patients, they lasted only for 2 to 3 years, the antibodies. But we are not sure how many patients infected in 2019 or 18 or 20, and maybe some of the patients or healthcare workers, they have antibodies we didn't know. Because MERS-CoV initially, during the pandemic, was a severe disease, but after that, we're very milder and coming after that. And we had several cases in 2018. So the concept I introduced, I would like, during doing the COVID-19 serology, I don't have any remaining from the MERS-CoV, and this is like giving false positive result. So it's done always together, the SARS-CoV and also the MERS-CoV. So MERS-CoV totally negative, and all the antibodies what we have nowadays is just only from coronavirus, especially the SARS-CoV-2.
Yes. Are you advising for the fourth vaccine?
طبعا, it's not the fourth vaccine, it's the second booster. So the second booster vaccines, yes, for immune compromised patient, I think it's coming. For immune competent patient, the question always coming, what's the protective antibody titers for immune competent? And if I measure the antibodies by Euroimmune, others is measuring by different antibodies. But nowadays, until now, there is no consensus against the immune competent, but immune compromised, I think is coming.
Thank you. My question, Dr. Abdurrahman, your excellent presentation, it's always concern about COVID being correlated with the mortality due to the thrombosis, and even the vaccine with the thrombosis. So do you think patient COVID per self, COVID-19, is it thrombogenic by itself?
I think so. I think it's a prothrombotic state. From large meta-analysis, it seems higher than the non-COVID patient, especially in the prospective studies. So I think it's a prothrombotic state.
Okay, so you mentioned in your study the thrombotic outcome in your study is not like the international study. What do you mean by that?
I mean, we find the venous thromboembolic event is similar to non-COVID patient, which is almost 10%. It's expected 10 to 15% of the ICU patient, they will have thrombosis. We did not find a higher than this rate regarding the venous thromboembolic event.
Yes, thank you. For how long you will treat COVID-induced thrombosis?
Probably 3 months, and the recommendation is not more than that.
Okay. Do you think there is any correlation between the BC positivity of the antibodies and the duration of the COVID, the duration of your anticoagulation?
Again, Dr. Farja.
Because this was a question for me, COVID-induced thrombosis, for how long I'm going to treat those patients? And some of the experts, they correlated with the antibody. As long as his antibodies is positive, you need to continue on an anticoagulation.
I'm not sure if it's true. The risk of the recurrence, for example, of thrombosis is correlated to the antibody in the patient. I'm not sure if there is any studies that looked at it, but I think there is no good study to suggest a higher rate of recurrence of thrombosis in this patient if you stop anticoagulation at 3 months. There is no signal that they will have a higher risk of recurrence after 3 months.
Okay, thank you. My question to Dr. Riyad Al-Faqih, you presented in your slides that lymphoma mortality were higher in compared to multiple myeloma. Is that related to the conditioning or the disease by itself?
Well, it's related to the anti-CD20, probably.
because you're wiping out the cells that make the antibody. Similar to the CAR T-cell patients, they did not do well, 41% mortality. And this is probably because the B cells are gone from the CAR T-cell anti-CD19, and same happening in lymphoma anti-CD20.
Yes. The second question, you presented that for the first time there was decrease in the transplant from the European study. Do we know what happened to those patients? Did it affect the mortality or their morbidity of the disease later on?
So the Spanish group reported their outcome with the COVID, outcome of transplant and hematology patient. The transplant patient was, the mortality was 17% for O to 18% for L. So pretty much matching the CIBMTR data.
Okay.
So the mortality is higher in transplant patient. And in our data, it was 4.4%, which much higher than the general population, but it's not as high as the others because probably we have a younger generation. Our median age was 35 and no comorbidities or low level of comorbidities. Plus, again, the healthcare system was not overwhelmed in Saudi Arabia, so these patients had access to tertiary and quaternary care centers.
Okay, thank you. Dr. Al-Askar, he has a question.
Well, thank you. Actually, 3 elegant talks about COVID-19 and effect on hematology, and more elegant questions that you questioned the panel, I guess, and it answered my question. So I don't have any question, and for the sake of time, I guess I will not proceed with the question. I could just talk to the audience and to the panel, I mean. All the questions have been answered, I guess, and thank you again for your...
Can I have one question for Dr. Fehna? Actually, a lot of people talk about antibodies, but we don't hear about cellular immunity. Why? Or cell response. I've never heard like a study about cellular immunity.
So if you are questioning like the cellular immunity, there is, for immune competent, we have now data, and we would like to submit it. So we measure the T cell numbers all, and we measure the interferon gamma assay, both co-cultures with the COVID-19 proteins, and this is very easy technique. But the most important, if you would like to take the immune compromised patient, this is very difficult because they are taking immunosuppressive medication and suppressing the T cells. And whatever you'll do functional assay, it's not really good because it's affecting by the medications. So the easiest for us to measure either the plasma, long life plasma in the tissues, or the measuring the antibodies, or measuring the cellular for immune competent patient, and this is nowadays we have a lot of papers.
All right, thank you very much. For the sake of time, we'll have a break for like 5 minutes or so, and then we'll come back to the next session. Thank you very much.
يعطيك العافية. شكرا. يعطيك العافية. يعطيك العافية. يعطيك العافية بدر الله يستر امرك. نتشرف فيك. السلام ورحمة الله وبركاته.
And also thank you for the scientific committee for inviting me to be here and to represent perspective from regulatory perspective. And I think this is really healthy interactions between the regulators and the practitioners. And also the industrial. So the main scope of this presentation is about the regulatory approval for clinical trials in general and the gene and cell and gene therapies. Yeah. So the scope of the presentation, as I said, it's about ATMBs. Maybe I can use this one just. Thank you. Okay, great. So the scope is about ATMBs, and ATMBs is regulatory terminology. So, and more focus in this presentation about the cellular therapy. Also, I would like to address the concept of point of care manufacturing and the quality system related to this, because it's also with the CAR T cells. If we look to recent trends, that there is decentralized procedures, which is they produce it in the hospitals, the CAR T cells, and also the centralized procedures where they have to produce the CAR T cells or the manufacturing of the CAR T cells outside in one centralized place. Also, I'm going to share some of my own experience from regulatory considerations. Also, some learning lessons from our perspective, and to go over the roadmap for the guidelines that to help the practitioners and the people involved in this project to find the right guidelines. Not sure how to use this. This is automatic. Okay, why it's important from regulatory perspective? There's too many factors actually why we think it's really important, and I'm not going to elaborate more about the medical needs for ATMBs in general and what can they provide for the patient. I think this has already been addressed, but also there is another perspective related to the ATMBs, that the limitations in the manufacturing perspective. So that means for example, the accessibility to the local patient will be a lot less. So that's why we need, from regulatory perspective, to give special attentions to these pathways, so they can have more accessible to the patient. And just to give you an example, with the CAR T cells, it's autologous and it's a personalized medicine. So you can imagine that there is a very few type of product will be produced per year. Another thing is that we expect a huge number of clinical trials, and this is from the studies that we know, and also in the development and the pipelines of worldwide. It's always going back, I'm not sure why. Okay, so maybe, yeah, that would be better, thank you. So, okay, so yeah, again, gonna go next slide. Okay. In this slide, actually, what I want to present here, that there is two perspectives. In the clinical trials, there is a huge emphasis from the academia, or we can also elaborate about the hospital settings that really comparable to the industrial in terms of the productions and development of CAR T cells. And if we look to the just the recent years, they have matching between the local from research perspective and also from industrial. So that's a sign for us as regulators that when it comes from research settings to directly to regulations, that comes with a lot of gaps in terms of understanding the regulations related to the industrial. Although the industrial usually they have more aware of the CAR T cells, and so that emphasizes our role to be more transparent and to introduce what CAR T cells is about. And also wanted also to hear and to show some of the products that we already have and be experienced with. We have CAR T cells approved, which is Kymriah, and also another gene therapy approved. We have a product that been under review right now, multi-myelomas and SMA. They are under review right now and for registrations. For clinical trials, we have products that already been approved for hemophilia A, and also this is from the gene therapy perspective, and for the CAR T cells perspective, we have the product that's been under review and in the final stage, I believe, for the CAR T cells for the ALA. Again, from regulatory perspective, usually we have to emphasize more about the classification of the product. We are talking about the long-term commitment and the long-term of this type of product that we are going to produce. Part of it is the classifications. And just want to emphasize that the classification could be really important. We have published guidelines for the classifications, and just to emphasize that these type of products evolve in every day. So it's really good to visit the classification pathways if it's not clear, or you can consult for the FDA. And as we know, we have some of the products, like for example, with the combination products when they use the medical device, for example, with the biological. So the ATMBs in general, they could be part of a huge variety of technologies, actually. And the case that I'm trying to represent here is more with the cellular therapy. Point of care manufacturing, it's a concept. It's not really new, it's not really old, but with the CAR T cells for sure, only maybe 5-6 years. And recently, I think with the successful story from Barcelona hospitals, they produce with the CAR T cells with hospital exemption pathways, which is a license specifically for the product. We just want to emphasize that if you want to produce it to increase the clinical trials in the country with point care of manufacturing, there's some perspective that you need really to look to it. For example, the facilities and how to deal with the viral vectors. The vectors in general, if it now we are dealing with usually with the CAR T cells with the lentivirus, there's a perspective for that. And also could be also for non-viral vectors, that could be also perspective, and you deal with it as a product. And I will elaborate on this part actually because it's really sensitive. The analytical procedure for testing for this product is crucial, and it's a common business with industrial. But when we have point of care manufacturing, which is based on the hospital settings, usually this get less tensions, which is really crucial to the product. Of course, operations and, for example, the semi-closed systems, quality systems in terms of the documentations, in terms of the trainings, to comply with the GMP, and there's a lot of perspective in this, and regulatory affair. So point of care manufacturing actually comes with a lot of regulatory perspective that we need to work together in this sense. And then with the viral vectors or the technology that's being used in the CAR T cells, what I want to introduce here that there's too many technologies that been under research right now, and some of them is really They show some promising result. And for example, but the main concept from regulatory perspective here, that some of these technologies is very well established and mature, and some they are less mature. So when you consider this as a technology in your product, that means if it's less mature, that means you need to have to support it with some supportive studies to ensure that this technology is, the effect of this technology is very clear. And usually with the CAR T cells the lentiviral is the product, but there's also other options of viral vectors that could be produced in future. When you deal with a viral vector, and this is part of the, as I stated, there's a facility and there's a vector, the product is considered to be as a product itself. The applicant, which is the point care applications, if they produce it internally or they outsource it, they need to take care of these type of parameters, which is the safety, for example, the sterility, the detoxings. They need to check it because this is the result there will affect the result of the clinical trials in terms of identity, purity, dosage, potency, and it's a list of requirements. You can find it also in the guidelines of the CAR T cells. But just want to emphasize that the quality of the viral vector, it will be reflected to the procedures that you have. So as much as you can look to these quality to be consistent and high and released based on the high quality, it will be reflected to the patient itself. And also paying attention to this is crucial because when we move from clinical trials to commercial, all these data will be reviewed, so that you need to be consistent all the time. And here, when we look to the operation model and using the semi-closed systems, I'm just giving examples of the two commercial products, Clinimax and also Concon from platforms, and they show really promising to may have more accessible to the clinical trials. And from our perspective, as we know, this is really what the machine can done inside the productions. For example, after you get the cell collections, you do the separation and selection activations. From our perspective, these operation units, and plus each one of these has a critical process parameters. So whatever we look to these operations inside the machines to be reproducible and to be efficient with a certain degree of quality, because the production of the CAR T cells is based on process. How you produce, so the process will create the product. So that's why we try to emphasize this and to validate these type of machines as a closed system. And just want to emphasize there is a lot of product actually in the market for a closed system. For example, the big giants for Almighty, they also join this race to produce a system, the closed system, and will help with personalized medicines. Yeah. And from our regulatory perspective and from our experience, I just want to highlight some of this perspective. One of them is, and the most important part, and we pay attention to the CAR T cells, that the source of the material, it's variant between patient to patient. So that's really hard to, from regulatory perspective, to prove the consistency. So this is really need to be designed from the beginning. So this factor is against the CAR T cells itself, but it needs to be really designed from the beginning. So all the factors need to be there. Also, because of the number of the runs of this clinical trial or the product and batches, because it's a personalized, it's produced per patient. So we have limited number of the product to establish stability studies. So that's something we always work on it. That's really against our wills when we try to review the stability program because there's no much of data. Another things about the transportation and storage is that you are working with live cells. So live cells need to have special tensions and special requirement, and this is from the pathways. Again, the most important concept actually for the process development, because when you do the clinical trials, you're also doing process development in terms of characterizations. Maybe your process is not going to be changed, the scale is not going to changing, but you need to have some kind of support to the product and to move from clinical trials to the commercial part. And one important aspect is the critical quality attributes. So most of the clinical trials of the CAR T cells, or they share the same critical quality attributes, but there's some also slight differences. So these need to have some tests. Again, GMP is a crucial factor, and the requirement for GMP, that's really important. We have a published guidelines for GMP, and we also can provide some consultations from regulatory perspective. One more things about the unique things about CAR T cells actually is what can be released and what can be not released. And this is not common with any medicines. Usually there is a release specification. If it passes, they will be released. If not, the batch will be disposed. But again, this is really depend. Usually part of the file is to do a specification, auto-specification decision tree. And part of it is to show if you have these certain of auto-specification and certain parameters, then it's not releasable. And this is the agreement. And if it can be other part of the parameters, like for example, low viability, this will be depend on the medical director. And this will depend on case by case and the scenario related to it. And just to give you general information, I think with a commercial product, usually 30 to 40% are out of specifications. So, but this is again a part of the CAR T cells. Another general consideration from a quality perspective that we consider a viral vector is part of the active substance and it's not material. That means you have the company or the applicant need to provide the full supportive information. And this is from experience. Another things about the challenges is to have the risk-based approach. So as we said, it's always the evidence and justifications that always comes from the science, but it's really limited. So it's always good to have this empirical data that can support you when you move from one CAR T cells to another part of CAR T cells, as if they share the same platforms. Again, assessment for the technology and bridging study is really important. And this is really when we try to emphasize that with experience, you can gain and bridge some studies from the first product to another product if you design it well. And this is from our experience. Another important topics that we always see is the potency test and the validations for the potency test. It's very complicated, but also this is something you need to, as an applicant, to pay attention to this because really this will reflect on the studies and the document that you provided. Again, the manufacturing process consistency, that will be related that, and process validations. So you cannot do a process validation for 3 batches only. This is part of the registration, but there is a need to have a verification steps that you can include all the product within time, even the bad one or the failure one, which will have a trend analysis, and that will ensure with the future and allow you with the future that you have consistent procedures. Industrializing procedure in academian process, for example, not everything's happened and works in the research perspective can go to industrialize. There is a transition period or transition phase, early communication with the regulatory that will help with this to standardize it. But again, it's a promising, they have high potential. This is just want to emphasize that we within Saudi FDA actually we started a project and team specifically for ATMBs, and they've been trained, and we have some internal committee and also outsider international committees that led for CAR T cells specifically and also for ATMBs. And this team now is translated after 3-4 years to a whole department that dedicated everything's related to ATMBs and part. So we also been part of the ICH. We have members that been participating in ICH and the group committee to write the guidelines. And again, why I'm showing here the roadmap with that we are following the international practice guidelines. So these with the FDA and EMA and also the MHRA, we have our own guidelines, but the point here is that these guidelines, they share the same science, same regulations. So we are following the international, so to have more accessible to our local patient, to our local hospitals or the local companies, when they follow our regulation, that they can be outside also. Again, these 3 important guidelines, all of them published, and you can visit them, and we expect more guidelines to be part of this and to explain it more. Just to finalize, here is some of the learning lessons and remarks. Again, ATMBs is very complex topics. We are working on it within Saudi FDA as a risk-based assessment. We cannot compare it with other products, but just to make it sure that these products are safe and more to the patient. Again, the most important concept that there is a new regulations, a new concept for everybody, for industrial, for also a hospital applicant, and also for regulation worldwide. Therefore, more and proactive and early engagement with the regulator will help a lot to have right regulations. Thank you so much. Yeah.
So thank you very much, Dr. Abdulaziz, for the great talk. We're going to have the questions at the end, so we're going to be moving now
Thank
to...
you very much, Dr. Abdulaziz. We will leave the questions till the end.
Okay.
Can you allow Dr. Khalid Saleh, please, to moderate?
Right, so it's my pleasure to present Dr. Saeed Turki. Dr. Saeed Turki is a graduate from King Saud University in 2004 with an MBBS. Then he moved to Oxford, where he obtained his PhD in bioinformatics. To Cambridge, I shouldn't say Oxford. And then he moved to Harvard. Right now he is heading the ANWA Medical Laboratories, and he is a consultant to many organizations, including Ministry of Health, King Khalid University Hospital, and UAE. He will be talking to us about reporting deleterious germline variants in hematological disorders, from where to start. Dr. Saeed, the floor is yours.
Thank you very much, Dr. Khalid. Assalamu alaikum wa rahmatullah. Good morning, ladies and gentlemen. And I would like to thank you, Dr. Al-Askar, Dr. Badr, and the organizing committee for your kind invitation. Can you show the slides, please? So in my topic today, it will be a gentle, thank you. Perfect, thank you. So it's going to be a gentle introduction for the reporting deleterious germline variants in hematological disorders. Sorry, this one, okay, thank you. And I think we are always focusing on the somatic mutations when we are dealing with hematological disorders. And today there will be a special focus on the germline. This slide presents the workflow or the timeline for the germline mutations when it's affecting or happening at the sperms and eggs, then into the zygotes, then affecting all cells in the babies and inherited to the next generation. Unlike the somatic mutation where it's happening after the zygote stage, affecting few cells, and usually is caused by environmental factors with some predisposition in germline, and usually is not transmitted to the next generation. So in my talk in 15 minutes or so, we'll be talking about what's the germline mutation landscape. We'll discuss some reporting guidelines, and finally, we'll see how this comes together as a workflow. So how important is germline mutation and how common it is? So there's some studies in the recent years that says it's 1 in 12 patients that will come to the clinic with a germline component, up to 1 in 6, which is really high. So let's see one of the first big studies that's happened in this space in St. Jude Children's Research in 2015. They basically sequenced more than 1,100 patients using whole genome and whole exome sequencing data. And they found across different tumors in young patients younger than 20 years old. And they found its germline mutation in 8.5%, which is 1 in 12. If you look at this figure, you will see there's so many different cancers involved. Some are solid tumors. But on the top right side, the leukemia represents 25%, Hodgkin lymphoma 7%, non-Hodgkin lymphoma 6%. So this is really a big number, almost 40% of the patients, young patients with tumors have a germline component. And if you say, this is too big, let's just focus on the patient that comes to our clinics with a hematological malignancy, and we want to see if they have a germline component. So this is a smaller study where they have 67 patients referred to hereditary hematological malignancy clinic, and they found 12 patients representing 18% or 1 in 6 patients. So clearly germline mutation is a big component and to be expected in many of our patients. So when to suspect a germline component? Of course, the personal history and the family history is a big part. For example, cytopenias with excessive toxicity with chemotherapy or radiation, if there is multiple kind of cancers in the family or multiple affected or usually unusual age for the presentation, or with the physical examination when you see these morphological features that will give you clues on the germline component. And this table will show the breadth and the spectrum of different components. For example, in the ELANE gene, beside the neutropenia, we expect to see some skin and the growth features. In the GATA2 gene, beside the anemia, neutropenia, we also expect to see immunodeficiency. And the hematological malignancy that comes with with these genes, could be bone marrow failures, MDS, AML, or lymphoma. So it's across the spectrum. And not only that, they come in different flavors: autosomal dominant, autosomal X-linked, autosomal recessive. So clearly there is a huge spectrum of germline mutation affecting hematological disorders that need to be paid huge attention for the patient and their families. So what are the methods that we should use for germline mutation? With different variants, we expect to see different, there is many biomarkers. Most important ones and most common is the single nucleotide variants, followed by insertion deletions, copy number variants, structure variation like gene fusions, and clonality. And for each biomarker group, there is a method that is optimal for detection of that biomarker. For example, real-time BCR is good for point mutation, insertion, deletion, and fusions. Capillary sequencing or Sanger sequencing is mostly for the first two, but we have FISH, we have MILPA, we have arrays, and we have next-generation sequencing, which has the promise of actually detecting all kinds of biomarkers in theory, and is proving to be very valuable. Now the question is, what is the tissue to confirm the germline mutation? So blood is definitely not helpful here because it's a cross between the cancer itself and the germline. So we wouldn't know which one is which. So it's not helpful for confirming the germline, but it can be the starting point. Buccal swabs is good, but unfortunately, it's sometimes contaminated with WBCs, so it's not going to give you a definitive answer. So it's not the best sample type to confirm germline. Hair follicles is great. It's not that invasive, but very difficult to actually extract DNA in the laboratories, given that how small is the specimen. So it can be used in highly developed and advanced labs. Finally, is the gold standard is the bunch biopsy, skin biopsy, basically. It's a little bit invasive, but actually this is the golden standard to confirm germline mutation in hematological disorders. So coming to the second part. So if we have a mutation, how do we report if it is deleterious or not? How do you trust my opinion versus Dr. Musa's opinion versus someone else's opinion? So we have to have a guideline. And the gold standard here is the Acmg Guidelines, the American College of Medical Genetics, published in 2015. And there is a barcode here to scan it for reference. It's very extensive. They came up with an extensive criteria to classify variants. And as you see, I'm not going in any details here, but for pathogenic mutation, for example, they have criteria. If the evidence is very strong, strong or moderate. If I zoom in the very strong evidence, it usually starts with loss of function. Truncating mutation, frame shifts, usually considered very strong evidence. And then they develop this even in a similar way, where, for example, you have the benign section, the pathogenic section, and how the evidence will support this side or that side according to many criteria. The first one that I will only talk about is the population data. So how common is a mutation in the databases for whole genome or whole exome? If it is very common, as you expect, it will be strong P9. If it is very rare, the evidence will be stronger. So what is the database that we usually use, or what is available now? Many of them. But I will just mention one of them called NOMAD. This is an amazing database with almost 100,000 plus whole genome and whole exome. It's freely available. You can search for any gene, any mutation, any location, and it contains so many different populations around the world. For example, you see how they are related to each other. The orange is the South Asian, the Swedish is the purple, Finnish, Ashkenazi Jewish, Latino, Korean. Unfortunately, Middle Eastern is not well represented in this, but this will change, inshallah, in a couple of years when more data is being poured in this database. When you look for one gene, for example, you will see this interface. The black barcodes is the exons, and each exon will represent how good is the coverage across the 100,000 patients. And if you zoom in more, in one of those exons, you will see a list of mutation. Each row represents one mutation with a classification, pathogenic, likely pathogenic, etc. And if you click on one of them, then you go into the deeper resolution. How common is that mutation in different population? You see, for example, here, the allele accounts in different population. We found 20 alleles across 100,000 patients. And then you see there is none of them have a homozygous mutation, which tells you that this is a very rare and probably important mutation. And the allele frequency is extremely low. So if you see a loss of function mutation in this database, and it is as rare as this one, then the evidence becomes very strong. So when we use Acmg guidelines, Sanger sequencing, NGS, how does all of this come in a workflow in reality? Usually, bone marrow in the lab, at least, the workflow starts with the bone marrow initial workup, morphological assessments, flow cytometric and immunophenotyping, cytogenetics and FISH, and molecular studies. So all of this usually starts with the bone marrow biopsy. And assuming that the current practice is use NGS, and the NGS panel is big enough to have predisposing genes, then we are going to look for a mutation with VAF above 0.3. What is VAF? VAF is variant allele frequency. If it is above 30%, then we suspect it's a germline. It's not the final answer, but it's suspicion. So we will go for a skin biopsy in order to do a comprehensive germline testing. So let me focus back on allele frequency. What does that mean? When we do NGS, for example, Illumina platform, and we are sequencing millions of reads, we end up having thousands upon millions of short DNA reads. And the first step we do is we don't know where they're at the genome, so we have to map it. So a program will go and take every read and start screening and mapping it to the genome. It will do this for all the reads. And then once it's organizing every read, where does it fit in the genome, another software will come and do the variant calling. It will start screening vertically, looking for difference between the reference in red and the reads in black. And you'll see here the reference there in red is A, and there is C, A, C, C, C. So we are looking at a change from A to C at that position. If we suppose there is 100 reads covering this region, and the normal allele is 55 reads, so this is a 55% allele frequency, and the C is supported by 45% reads. So this range tells us that it could be a heterozygous, 50% from mom or dad has been inherited, but it could be also somatic. We have no way of knowing which is which. But if this is very low, like 5%, 10%, this is unlikely to be inherited because the germline usually between 50 and 100%. Anything below that is usually somatic. So in that case, we go for a skin biopsy, we do the germline. The other way of approaching this is if the clinical history is so strong, the patient comes with a personal history of 2 or more cancers, young age, or strong family history, so we can go directly for a skin biopsy. And if the germline testing show deleterious mutation, then surveillance will follow, segregation study in the family, and assessing the related donors for familial variants. So with that, I hope that I was able to describe when to suspect a germline component and how important it is currently. What are the methods used? NGS is the gold standard and confirmation by Sanger sequencing. Tissue is, buccal is not optimal. Skin biopsy is the gold standard. Guidelines for interpretation is the Acmg 2015 guidelines. And the Nomad is one of the most important database that we have free of charge with 140,000 whole exome and whole genome. Thank you so much for listening.
Thank you very much. Very elegant, clear, and concise presentation. We will leave the questions at the end. It gives me pleasure to present Dr. Masoor Radhui. He graduated from King Abdulaziz University, Jeddah. Then he carried his training in internal medicine in McMaster, followed by hematology as well as a fellowship in Toronto. He also holds a Master of Science and also recently completed a master's degree in health economics and pharmacoeconomics. Currently, he's an assistant professor in the University of Jeddah, and he will present patient-reported outcome measures in hematology. What is the best tool?
Thank you, Dr. Musa, for the kind introduction. And I would like to thank Dr. Ahmed and the the committee who invited me to present this talk. So I will be presenting a patient-centered related outcome. So at the end of the presentation, we will realize that patient-related outcomes are not equivalent to clinical outcomes. It's an important domain that has principles, and it has to be done in a very specific and methodological way that to have it incorporated into the clinical practice. At the same time, application of patient-related outcome measures is complex, and research is needed to understand how to incorporate it into the clinical practice. Now, before I go and discuss about patient-related outcome, I want everyone here to think about examples of how patients interact with us. So these are a few statements that have been made to me while I was in the clinic. For example, I had a lady who had an iron deficiency anemia. She was very adamant about not using iron pills because they were causing constipation. At the same time, 3 days ago, I usually give my cell phone number for emergencies to patients. So a patient called me the next day after I saw her in the clinic. She had a provoked venous thrombosis, DVT, a simple DVT. So I started her on anticoagulation and so forth. And her only concern was, because I counseled her about bleeding risk with the anticoagulation, am I going to die from a bleeding? So, and so forth. So you can realize that even when someone has an acute leukemia, it's not just they're thinking about the overall survival or how the treatment is going to be. They are also thinking about how the social effect is going to be on their life. For example, I had a lady who had acute leukemia, and I'm discussing with her how complex is this situation and how grave the situation is. And she's only thinking about her family, that she has 4 kids, young kids, her husband is working. If she's going to be admitted for 1 month, who's going to be taking care of their children? So it's patient-related outcomes are not just clinical outcomes. They are different. Even when we talk about clinical outcomes, this is a comparison that was done between how physicians assess peripheral neuropathy in breast cancer patients. So if you realize, if you look at the first graph, clinical severity, majority of the clinician assessed the patient did not have any peripheral neuropathy. But when you compare it to the patient, how they assess the neuropathy itself, you'll find that there was a lot of discrepancy between how they perceived the neuropathy versus how the clinician did. So for example, clinicians were less likely to assign a severe or very severe score to the patient, while the patient themselves will assign that they had severe or very severe neuropathy more. And in addition, in this study, they added patient interference. So is the patient neuropathy is interfering with their social life? So also there was a discrepancy between how patients labeled themselves as severe neuropathy versus how it affected their life. So what is patient-centered research? So it's anything that is related to patient feeling, their symptoms, and any effect of the medical decision. And this is done without interpretation of any physician or any observer. The patient themselves are talking about their experience when they have the disease or they're undergoing treatment. So it focuses on opinion related to health, quality of life, or functional status, in order to identify patient needs and prioritize and creating opportunities to address them. Now, we do have definitions. The FDA and the European Medical Agency does have specific definition for this. And this is why the definition was put on, because they wanted to incorporate this into the clinical research itself. They didn't want only clinical outcomes. They wanted to have patient-related experience and opinions incorporated into research. Now, the way that we see clinical outcomes, we see them at direct measures or indirect. So we have objective, for example, we do have studies that looking at overall survivals, or subjective, we do ask sometimes patients how they're feeling. So for example, anemia, is the fatigue is improving, and so forth. But medical benefit is beyond that. It's an umbrella which encompasses symptoms, functional status, adherence to treatment, and satisfaction. And this is only just part of the treatment. So we have to look at what is the medical benefit and what does it encompass. It's not only our opinion that the clinical outcomes, but it also goes beyond that. Now, why patient-related outcomes is needed to be measured? It's a tool to improve communication between the patient and the healthcare service. So sometimes the PRO can be a sole indicator of a disease, for example, migraine. Sometimes it's not related to clinical outcomes. It's related to the effect of the treatment. For example, if you have antibiotics that requires patients to come every day to the hospital to have it intravenous, so that's an effect. Waiting time for surgery. So we know that, for example, in some countries, the waiting time for elective surgeries is 1 year. Someone who has hip pain, he's going to live with this hip pain for 1 year before he will undergo orthopedic surgery. And sometimes the PRO is a metric or indicator for patient safety. We know that in America, United States, the Medicare rewards hospitals who prevent falls in hospitals. So this is all considered to be PRO. In order to have to measure the PRO, we need to have specific tools or instruments. And usually these are questionnaires filled out by the patients. These questionnaires can differ according to the measurements, so functional status, health-related quality of life, symptoms burden. They can be general assessment or disease-specific, and the collection itself can be different between paper and electronic. Now, they are lengthy, so this is one of the forms that discusses, looks at the quality. So I've only presented only 16 items, but in fact, this questionnaire has 30 items. And I'm going to talk about the issues about the Prom or patient-related outcome measurement later on. So how do we apply it in oncology? So they did in RCT, where they systematically collected feedbacks from patients using specific questionnaires, and then they related to the team itself. So it's auto-generated, so it was a paper and electronic collection method, and they found out that those patients who participated in and filled up the Prom, they had higher health-related quality of life measures, they had higher treatment adherence, they avoided hospital admissions, and they have a higher survival rate at 1 year. So if Prom is very effective and can be used in oncology, how is the attitude of the oncologists in incorporating Prom into their practice? So this was a mixed method synthesis of qualitative evidence where they interviewed oncologists, and the results were some positive, some negative. So the positive was prioritizing, focusing on issues related to patients. So many of the clinicians said that they will not focus on issues unless the patient brings it to them, and the Prom was helping with that. Also, some sensitive issues. So we know that there are a lot of questions by the patient themselves who are deemed to be sensitive, and they're not going to ask them unless they are prompted. So for example, one of the questions they were asked, how many platelets do I need to have to be intimate with my partner? However, clinicians differed on whether these informations were helpful clinically or not. So some of the physicians felt that it was already collected. They don't need to collect them themselves. And also they said that sometimes the patients, when they relayed their experience, they were overstating them. And some of the problem with the Prom is that patients can convey information that you don't have solution for that. For example, we do face a lot of this in private sectors where patients complain about financial burden, and we don't have any solution for that. And the last thing was the sustainability. For example, if you are going to incorporate this system, is it going to be sustainable or not? Do you have the infrastructure to support that? So if some of the aspect that I need to emphasize is the issues when using Prom, validity. So you have a tool that can be reliable, can measure effectively, can respond to changes. The size of the items, so we know that, for example, the questionnaire that I presented had 30 items. This is a very long, and we know that the participation is directly related to the length of the questionnaire. Number of measurement of tools available. Unfortunately, the Prom that we have, the tools that we have here in the literature, it's very vast in numbers. So we don't know which tool to use. Costs related to the Prom, as I explained, that if you are going to use a Prom in your clinical practice, the collection data is going to need a data collector. You might need to have a face-to-face interview, so there's an extra personnel in the clinic with you. Feasibility, how you're going to collect them and store them. And then lastly is the culture adaptation. Every tool is validated in their own culture. So an English tool, or tool in an English language, you cannot really simply translate it to Arabic and say that this is going to have the same validity. So whenever we're going to translate a tool or a questionnaire, we need to be very careful in how to use it. Okay, so I'm going to go on and move. This was all theoretically wise, so I'm going to move on to a practical. So we're going to review, this is a paper that reviewed patient-reported outcomes in multiple myeloma trials. So they looked at 25 pivotal trials in multiple myeloma, and they wanted to know if these trials were collecting patient-related outcome in addition to clinical outcomes. Only 17 out of the 25 collected that. But they also noticed that when they measured the patient-related outcomes, majority of them used 2 measures, but also 1 in 10 used 4 measures. Type of measures also varied, so majority of them used QLQ 30, but also they used other methods. So the conclusion was there was some heterogeneity in using Prom in clinical trials itself. And this was affecting how a cohesive measurement process will be presented to clinicians in order to make a decision. When even non-offering treatment causes issues, so not everything is related to treatment. So this was a Prom related to watchful and wait. We know that in follicular lymphoma, we have watch and wait strategy. So how does, even the watch and wait, you're not offering any treatment. How does this affect the patient? Patients don't remember and understand watch and wait. They found out this was in prostate cancer. For them, watch and wait was doing nothing or giving up. This was some of the statements. The doctor never brought watch and wait versus treatment. You could do nothing, but I think you could have a problem later on. This was their understanding. If you watch and do nothing, your cancer is going to obviously progress. It's like, well, you're waiting for the time to explode. This is what their experience was when watch and wait was presented to them. Even patients' own belief will influence their decision. So when you're discussing watch and wait, and it could be the right answer, age has an impact. So the younger you are, the more likely you want it to have treatment or willing to have treatment. So when you're talking to someone who is young, it's different between someone who is older if you're offering watch and wait. There's also, they noticed that physicians themselves, although they were offering different options, some cues that patients were sensing from the physician that prompted them to be pressurized in not adopting watch and wait. So for example, one man was concerned about the side effect of aggressive treatment, particularly impotence, because the radiation involved in the prostate can cause impotence. And he was willing to have a watch and wait option. His urologist frowned when the patient chose watch and wait. And he decided he was forced to have radiation. Family pressures. So maybe watch and wait is good for you, but patients, when they went home, their wife, their family forced them to have a treatment. So these are all patient-related outcomes. Whenever we are discussing about how the decision is made in the clinic, it's not just patient and yourself who is taking this decision. There are other factors that can be contributed to that. Now, yesterday when I was discussing with my colleagues, I told them that I'm going to present 2 studies on allogeneic transplant that does not have overall survival, treatment-related mortality, and GVHD as an outcome. Now, this could be surprising because yesterday when we saw studies, all of the studies were looking at overall survival, patient progression-free survival, and so forth. But this is an example of a patient-related outcome that is not familiar to us because they're using different outcomes. So they looked at patient characteristics and transplant-related costs with financial hardship and measures. So they found out that your income would decline if you started as a low income in a low income bracket, and if you're paying for the cost of the transplants. For example, if you're paying part of the medication, and this is in America, so there's a reimbursement and plans, medical plans that goes into this issue. Now, your income is not only, the odds of ratio for income is not only declining, but also you are going to financial hardship. So they asked them specifically, if your income declines, are you going to face hardship? So for example, unable to pay rent and so forth. So again, low income, they had, the odds of developing hardship was higher. Paying for transplant costs was also 6 times higher. So these are not related to the clinical outcomes that we are used to, but patients are affected by that. Lastly, this is a last example. So does driving distance affects stress and impair physical function? Again, these are questionnaire. Again, in a transplant population, there's no overall survival, there's no treatment mortality. They're just looking at patients' characteristics and looking at whether they can cause stress or physical function. You can see that, for example, let's say long-term partner. So unable to have a long-term partner, your odds ratio will be decreased. Household incomes, again, low income will have more likely to have distress and more impaired physical function. The final remarks, patient-related outcomes are not equivalent to clinical outcomes. They are important to pain that has principles. And again, I showed you that application of this new outcomes measurement is complex. Research is needed to understand how to incorporate it into the clinical practice. Thank you very much.
Thank you very much, Dr. Masoor. Excellent talk. We will move on to the last talk in this session. We're glad to have Dr. Suleiman Al-Ghannam. He is the head of population and health department at King Abdullah International Medical Research, KMARC. His background is in rehabilitation and physiotherapy after obtaining his PhD from University of Wisconsin. And he will talk about the role of electronic health records and disease registries in hematological research, reality and aspirations.
All right. Thank you very much for the introduction, Dr. Thank you, Dr. Badr, and Dr. Ahmed for this kind invitation. So here's the roadmap of what we're going to be covering in the next 15 minutes or so. I'll kind of highlight the role disease registry play to inform improvement population health. And then we'll kind of shed some light onto some of the potential role electronic health records plays in shaping future data generations. We all know that data generation is gaining huge momentum in the kingdom now, and with the increased reliance on electronic medical records, definitely this will increase in the future. Then we'll conclude with a couple of recommendations in future direction. So unfortunately, Saudi Arabia is a developed country, but face a huge burden when it comes to non-communicable diseases. Unhealthy lifestyle is prevalent. Obesity is on the rise. We have about 50–60% of the population either overweight or obese. We know that will play a role in many health conditions. Currently, as we speak, there are about 8 million individuals in the kingdom with a chronic condition. This number is expected to increase to 10 million in the year 2020. So imagine how that was going to play in our future burden of premature mortality and healthcare costs. We already know that premature mortality in the kingdom is much higher. Premature mortality is defined as death happening way earlier than the expected time. It is around 46%, much higher than developed nations. This also affecting health costs, and now with the healthcare transformation, health costs is playing a major role. About 4%, according to the Ministry of Health, increase every year in healthcare costs. So imagine the 8 million is becoming 12 million people with chronic conditions. So all of that, unfortunately, is going to pose an unsustainable burden. How do we address that? First, we really need to set the baseline. We really need to understand the burden of various health conditions. This is the first step, understanding your baseline, and then moving from there. So there's various ways to do that. We can rely on primary data collections. You're basically collecting your own data. And that's, if it's nationally representative about sickle cell anemia or any health conditions, it's really important to inform clinical and policy. But we know this is expensive for any disease. If you want to collect data nationally representative, you're going to spend millions of real to do that. And it is unfortunate leading us to much reliance on US-based data or North American data. Alternatively, you can try to rely on what we call secondary data that are collected already from other sources, either from colleagues who already have a database or a national database like a national survey, for example. It's cost efficient, but again, it does require initial investment, which again will be in the million. The other thing, a limitation, is that sometimes the data quality may not be as good if it is collected by the researcher themselves. So hence comes the roles of disease registry. They really help us set a baseline where we stand, and once we set the baseline, we understand the prevalence, then we can move to risk factors that either increase or reduce the risk of disease, complications, patient-reported outcome, as Dr. Masoor had mentioned. All of that is really important. Then the following step is design and implement clinical intervention, policy intervention, and then evaluate all of that. All of that is definitely going to play a role in something that you're going to hear a lot about in the next few years. And Dr. Masoor alluded to that briefly when he mentioned Medicare paying for performance. So in the kingdom, as we move in the next few years, we're going to hear a lot about value-based care. And probably many of you have heard the concept before, right? Essentially, value-based care is where we should be heading. We should be rewarding good performance, good outcome, rather than just a fee for service or a capitation mode where it's mostly prevalent. So how is that related to disease registry? It is related to disease registry because outcome is in the numerator. And disease registries are a major source that we're going to guide us about outcome. Other countries, especially in Scandinavian countries, have far surpassed Middle Eastern countries in terms of investing in disease registry. Sweden is actually one of the leaders, and one of the analysis by BCG company estimated that they saved about $7 billion in 10 years just from investing in disease registry. A huge registry in Scandinavian countries that kind of captured the patient from birth till death. Imagine that trajectory and the data infrastructure. So in addition to their help in improving health outcome, they do save cost on the long term. Other application is that really with comprehensive registry, we can understand local burden, national burden, GCC country, internationally, benchmark where you stand for any disease across the globe, as well as doing some sophisticated or dashboards to understand variations or what we call hotspotting within the kingdom. However, this is all nice, and definitely when speaking with researchers, clinicians, they really admire the notion of investing in disease registry. But the problem is when we sometimes talk to policymakers, they are competing priorities. You know, especially researchers. Researchers want to spend a lot of money on research. We know we're not spending enough on research in the kingdom, but sometimes there's competing priority. No, we have to treat patients. We have to train medical students. Those also cost money. So from the perspective of efficiency and competing priority, sometimes we have to rely on either or what's available. And this is what has been done in other countries. So in the United States, this paper came out, I think 2016, 17. It kind of argued that there's innovation in population health surveillance. And they stated that in 2004, 20% of physicians were using electronic medical records. This number jumped to 87%. This is a huge jump. And I would assume the same jump was achieved here in the kingdom. Many physicians now use electronic health records. So how can we leverage that to improving our understanding of disease burden and hopefully establish disease registry? Luckily, we're not alone in this. There's huge momentum in the kingdom as part of the transformation for value-based care, value-based healthcare. There's also huge interest in digital health, electronic medical records. One of the aspiration for the transformation program is to have an electronic health record for each individual. This will drive big data and understanding disease burden, as well as sophisticated analysis like AI and machine learning. So electronic health records have the advantage of population coverage. So I'll speak about the National Guard population. So we have a stable population, National Guard individuals. They are eligible, covers the entire system. There's integration across specialties, orthopedic, pathology, hematology, and so on. So you have kind of all the information from the various sectors. And lastly, there's longitudinal continuity. So you know when the patient is diagnosed, and you know when the patient is discharged or died from the hospital. So you have kind of a cohort within your system. So if you design it correctly, you can really have a powerful database. So currently, so I work with many clinicians, and many have a strong desire to create good data source from electronic health records with minimal human help. So I'll just spend a minute highlighting our current abilities, at least within our system. So luckily we have many registries in the National Guard, some of which are renal, diabetes, heart failure, and stroke. And within those registries, we can identify basic demographics, so age, gender, marital status, occupations, all of that without the need for human intervention or people collecting the data. Diagnosis, ICD codes, if the data is coded correctly, is captured, as well as lab measurement in some clinical outcomes. So that by itself, if you're really conservative in your registry or your idea of a registry, this by itself could be created for the researcher. Where we struggle, another tool or a tool that we usually complement this is what we call REDCap. Many of you are familiar with it. So if we have the data structured and clean, extracted from the medical record system, we could easily import it into REDCap, and voila, here's your registry. What we struggle with, however, is unstructured text. Basically, physicians' progress note, discharge summaries, and sometimes radiology finding. And ideally, you would want to have everything in your electronic medical record structured so you could really mirror whatever you want, but reality is that this is not the case. However, one of the things that we can invest in, and we're trying to invest in, is how to prioritize or how to identify our interest within the unstructured data for us to be able to extract automatically what we need. And I'll show you an example of some of our recent work. It's related to diabetes and hypertension. So we have a diabetes registry. We have interest to capture hypertension as a comorbidity. So within our system, we try to identify all the diabetics based on ICD code, based on medications, and based on lab results. So we got X number of patients. We are not 100% sure that those individuals are all the diabetic within our institution. So what did we say? We said, okay, this is the initial number we have. We know physicians in their progress note write the word patient have a history of diabetes, DM, HTN. It's a very common, and I got this from a physician colleague. So what we did is that after we identified the final number, we extracted around 10,000 patient progress note that are labeled not diabetic, not hypertensive. And what we did, we collaborated with a bioinformaticians who use in natural language processing to read those notes and flag the patient as diabetic if the word DM, the physician wrote the patient has DM, not history, family history of DM, but the patient has DM. And we found around, within with 10,000 patients, 1% of them actually were diabetic, despite the fact that we did not have ICD code for diabetes, we did not have any medication, no records. From 10,000, about 160 patients, we went and read the entire 160 patients, and they were actually, in fact, diabetic. So kind of a small step in that ladder. And this is the kind of momentum we're looking for, is basically relying on structured data and then complementing that from with tools like NLP. Luckily, the awesome effort within the hematology fields, I really like to see some of the registry. I really hope to see much more. With the reliance on electronic health records in the kingdom, we could definitely expand that coverage. The beauty of electronic health record is that it will allow you linking comorbidity from various registries. So I highlighted the example of stroke, renal conditions, all of that condition. If the data is really updated, you can link them across diseases. This will reduce cost. And finally, we heard today about the randomized controlled trials being on the rise. Disease registries will be a great tool to identify patient or candidate for various interventions. This is not to say it's easy tools, definitely have some challenges in terms of the data availability. The system has to be mature enough to extract those information for you to your registry. There's a huge cost or initial cost of implementations of the electronic health record. Not all the hospitals in the kingdom has it, but if they do, and they do allow extracting the data, this will be huge. Quality and reliability is a major challenge, even in mature hospitals like National Guard. The physician have to write an accurate ICD code, otherwise garbage in, garbage out. And finally, there's huge limited experience in that area. So we're really lacking experts who are able to analyze large data, who are able to conduct sophisticated statistical analysis. In terms of recommendation, I highly recommend working in multidisciplinary team. And I think this is some of the, or why we were able to achieve several registries, working as physicians, epidemiologists, bioinformaticians, and IT. Unfortunately, in many organizations, the IT works in silo. You really need to engage IT with a multidisciplinary team to be able to understand what can you extract and what cannot you extract from the system. And the other thing is, in working with so many researchers, many have great ambitions, and sometimes it's unrealistic given the resources available. So I highly recommend starting small, starting with one disease, starting with a registry as small as just the ICD code and basic demographic and patient outcome, and getting your residents, maybe an intern, to complement these registry. Once you have few paper coming out of this registry, it's a really proof of concept, and then you can promote it either through the partnership with the private sector to expand that registry, rather than staying put without progress because you wanted something expansive. And finally, and this is one of the things that we're definitely going to see on the rise in the future, is integrating various technologies. So you as a clinician working with a patient, you can easily ask the patient to give you their iPhone and look at their physical activity. This is an accurate measurement of the person's physical activity compared to asking them, do you walk 5 miles a week? So this is a technology within your hand, an iPhone, an iWatch, that could be integrated with the electronic health record to complement some data, either physical activity, it could be drug adherence, and so on. And we know this is on the rise in developed countries, so we might as well jump into that ship sooner. That's all I have. Thank you for this opportunity, and I really enjoyed the conference, and I'll be more than happy to receive any question with the great panel.
Thank you very much for the excellent talk. We will invite the speakers, please, to the front so that we can have discussions and questions. We really enjoyed the session, different topics and very exciting ideas. So I will start with asking question myself, and then we'll see if other people have questions as well. the first question is to Dr. Abdulaziz. How do you see the quality requirements for cellular therapy in Saudi Arabia in terms of the readiness of our institutions in carrying that, and what are some of the barriers that you can see from your experience?
Thank you for the question. I think in general there is a huge like challenges that related to the CAR T cells, and specifically, so this is the nature of the product, but also specifically with the changing of the applicant. For example, moving from industrial and pharma company to the applicant when it really comes to like the local hospital. So just to summarize, I think there's a lot of challenge. One of them is that regulation for CAR T cells need to be digested adjusted to the regulation itself. So usually regulators compare it to other type of product. Early communication will be one of the reasons as to be more proactive to solve this type of problem. And also another things maybe I can think about it, that the regulatory guidelines is not really easy to follow. This is general, universal comment. That's why most of companies, they have dedicated department for regulations. So I think those two reasons is the main one.
Thank you very much. I think we have another question, Dr. I think, تفضلي دكتورة.
Who's going to ask?
Thank you very much for all the speakers for this wonderful talk. My question is to Dr. Saeed regarding the NewMed database, where you mentioned that this represent different populations, but however the Mediterranean or Middle East people are not there. So what you do when you look, for example, at germ cell in one of our patients, it does not relate it to the reference. Do you go with the same rule, more than 30%, or you increase the frequency, and do you report it as new mutations, or you just close that?
So your question, what do we do for underrepresented population, basically, like ours?
In the NewMed, you use it now, currently, to
Right.
detect germline.
Right.
But you said our population, or in the Middle East, they're not represented at this time being. So if you get a germline, suspected germline mutation that's not represented, I mean, there is nothing in the reference, a variance, or how you report it, or do you take the same guidelines that it should be more than 30, or you increase your frequency level or threshold?
Sure. So for most labs, usually the baseline, the classical baseline, is to have 200 alleles or 100 patients or healthy people sequenced for a specific gene. So usually when we start, we have that kind of data during validation for a new mutation, for example. It's not always available, but that's the minimum classically where we can say it's not in our population. Now, I know in the last 3-4 years, most hospitals usually send out a lot of tests. What they should do is request that data back, because they will have at least 200, 500 patients. And that could be the small database that can be used in-house to understand how common is it. And your question is very important for two reasons. One, the general population database, although our population is not there, but if it is common there, then the mutation is unlikely to be pathogenic, generally speaking. So it is helpful on that side. But what do we do if there is zero in other population, but it's actually common in ours? And this happens with the mutation in MLP gene that's actually published by Dr. Moussa Zahrani and colleagues. That mutation is almost not seen anywhere else except in Saudi people, the 106 mutation, and the Latino, which I presented actually. There's only 20 alleles from 140,000 people. So we only discovered in Saudis, Kuwaitis, Qataris in the region, and this could be a founder mutation. So to summarize, it's very helpful, the database, even if it's not representing Middle Eastern, for common mutation. Number two, let's aggregate all the sendouts in a small database inside the house. And number three, communicate between hospitals. I hope there will be an effort to join all of these data, because I know Centogene, for example, they have at least 30,000 Saudi patients, whole exome. There's 30,000, let me repeat that again. Saudi patients with whole exome sitting in Germany in Centogene database that the country paid for. And actually, if you want that data back, they request a license. How much is it? 400,000 riyal per license. And do you get access for all of it? No. You can access 1,000 mutation or query per year. So this tells us the gap in knowledge is extremely important. If we continue send-outs without having a centralized database for our own population, in a few years we'll have very difficult time actually to report what is pathogenic and what's not. But for now, I think the available resources online is a fantastic resource.
That's a good example of how registries and databases can
Yes.
save money, basically.
Yes, exactly.
So we'll see Dr. Ayman.
Thank you all for the elegant lectures that you have presented. My question goes to Suleiman regarding electronic health records. They're fantastic, they're awesome. I mean, the benefits are uncountable, but I would just say something from the perspective of a clinician who has a busy clinic seeing 20 patients in 3-4 hours or even more, and he has only 10 to 15 minutes for a patient. I'm just correlating what is requested from me now, since I have a full electronic medical record, where I have to enter the labs, access the previous data to know about the patient, and then type in the history with my very poor typewriting, and then talk to the patient. So the time I used to spend with the patient talking about his problems and doing the physical exam, I have minimized to the least, just in order for me to cope with the electronic medical record. What do you have to say about this?
Thank you, Dr. In terms of the clinical care, here we're not talking about clinical care. If you are overwhelmed with patients, that's a system problem. I hear you. Here we're talking about the tools. Not all the parameters extracted from the electronic health records to build in the registries are actually from the physicians themselves. Remember, the labs, the initial vital signs that are presented by the nurses. Hopefully in the future we'll have tools that kind of augment the role that physicians does and reduce the burden on the physicians on completing the information. Most of the information that the physician fill in the electronic health records is related to the progress note or the management of the patient. And remember, as I highlighted, this is the difficult part to be incorporated into the registry. The structured data that comes from the lab, that comes from the vital sign, that comes from the patient length of stay is the easiest to be extracted. So we really hope, with the advancement in technology, that some of this information could be maybe dictated by the physicians using sound, and that would reduce or reduce the number of the patient-physician seats. Because I remember, I hear some of my colleagues who were residents in the US and Canada, I see more patients in Saudi than when I was a resident. So I think maybe it is a system problem if the physicians actually have the proper time. They really have a good documentation. But the bottom line is that we're stretched when it comes to data collector. Dr. Masoor mentioned the cost of data collection. This is the first thing I hear from clinicians when I say, hey, I'm Suleiman Al-Ghannam, I'm from Population Health, I'm interested in starting a registry. They would say, Do you have funds to people collect the data? And it's not always there. We really need to think outside the box when it comes to, we know this information is important, but how can we get it? Ideally, we should have more research coordinator, and I think Saudi Health Council is investing in this, that they hope in national registry they will plug in research coordinator within the hospital to help the physicians and the nurses collect the data. Even in developed countries like the United States, they're not the physician's job to fill the register. No, they would have research coordinator do this job.
Yeah, but I mean, filing registries is something else. But I'm just talking about the daily practice, how the electronic health records has affected us as clinicians.
Oh, yeah, that's a different thing. I'm focusing on electronic health records.
I just want to add something. I think it's valid, Dr. Ayman, what you said. And again, there's Dr. Suleiman said, registries are important, but this is where the healthcare system assessment comes in. What I presented today was only a small portion of how the assessment of the healthcare system and interaction with the patient comes in, because this is part of the patient interaction, patient journey into the healthcare system, and how we collect the data, how we use it. So for example, I only presented patient-related outcomes. There's healthcare-related outcomes, healthcare giver. There's also family-related outcomes, so how the family is coping. And also, of course, this is a health giver outcome. So they should interview clinicians and see what's their perspective when collecting the data and how to make it easier. As Dr. Suleiman said, that maybe dictation, template use. So I know I worked in one of the hospitals in Canada where they were using for writing side effects of chemotherapy. They had a template. So you will, for example, RCHOP. You won't write everything. You will just hit Alt and F4, and every side effect of RCHOP will be dictated into the medical record. So you'll say that I've counseled the patient about the side effects of RCHOP, including 1, 2, 3, 4, 5, 6. So maybe, and here where the research comes in, once we know where's the obstacles, the barriers, the IT comes in and finds a solution for a clinician. But we won't know where the barriers are unless we do the research, unless we measure the outcomes. And again, we are focusing only on clinical outcomes, overall survival, how is the patient is doing, but we're not focusing on other aspects, which is very important.
Please go ahead.
Thank you very much for the excellent talks. I'm not disagreeing with Dr. Ayman, but I guess it's very vital to have electronic records, various health registries. If you look at the problem, from King Faisal or National Guard perspective, everything is there, alhamdulillah. But if you look at less privileged hospitals, those belonging to the Ministry of Health, for instance, it's very difficult sometimes to collect data, not only for research purposes. If you have a certain mode of treatment, if you like to see how good or how bad you are doing, it's extremely difficult to, go to, the records of patients, case by case. It will take ages to collect these data. So at King Faisal, I was lucky to work at, different institutions in the country. I did the research at King Faisal, over 3 years. It needed me just a few hours to collect the basic data. But, working at other institutions, I will not mention names, sometimes I take 1 to 2 years with my doctors to collect the data and then to verify it, how accurate, how good it is. So, I know every system has its own advantages and disadvantages. And I guess we are going into a new era. We should have most of the things. I'm not saying it's impossible to have everything computerized, but most of the things computerized, so that, health leaders can make decisions. Otherwise, it will be difficult. Things will be made on speculations only and opinions of people with, okay, possibly expertise here and there, but will not have the whole picture. Thank you very much.
Just add on one thing. I agree with you. Nothing is going to be perfect from the beginning. But the problem that I think I've been here in the, I returned from Canada around maybe 5 years ago. The problem here is not about the perfect system. It's about that we don't measure. If we don't measure, we won't improve. And it's a general statement. I shouldn't even make a general statement. Maybe in Caremark they are measuring, so it's going to be unfair to say that institutes are not doing. But in general, if you're not going to measure, measure how you're doing your data collection. Dr. Saeed said that we're sending everything outside, for example. Now we have to pay $400,000 for a license that we could have done it easily here. But we don't realize that we don't have this. Maybe Dr. Saeed has this information, but I'm hearing it for the first time. But if we collectively have this information and process it and make a plan to facilitate it, maybe it's going to be easier for us. And this is where the gap is here. It's not that we don't want to, but maybe we're not really measuring. We don't know what we're looking for.
And if I may add to this, thank you, Dr. Musa, the point that I think having this dialogue is helping leveling the playing field. You mentioned something that, in other hospitals, they would probably have not even the diagnosis, but in advanced hospitals, for example, tell you who are the patients who are obese between the ages of 40 and 60 in Jeddah who are on dialysis in 2 minutes. This is the level of ability to capture. This is important to highlight to show that this is an existing capability within the kingdom. It's not outside. That will allow others and other institutions to say, well, at least the bare minimum that I can get is this. Or if I need to collaborate, I can collaborate with this institution to help understand within the area and not rely on external. I think this is one of the issues that it's not only in hematology, in all the fields. In the past few decades, we've been relying so much, especially in IT countries abroad. And once the the commitment or the contract ends, we lose everything. And the stakes are high. You're talking about sensitive data. So it's really important to have something local for the long run.
Thank you very much for our great speakers. We're really enjoying the discussion, but unfortunately we have to stop here and have the break. So thank you very much again, and hope to see you again.
maybe a bit after lunch, sorry, a bit lazy, but hopefully we'll have an exciting talk. And in this session, we'll have, this is the third session of the day, we'll be having 3 talks. First is a satellite symposium, and then another 2 talks. I will be chairing this session, me and Dr. Ibrahim Al-Matabi. Dr. Ibrahim is a consultant hematologist and bone marrow transplant from King Fahad Medical City in Riyadh. Myself is Dr. Amal Al-Bihani. I am a consultant hematologist and bone marrow transplant from King Faisal Specialist Hospital in Medina. So I will be presenting the first speaker in the satellite symposium for the day, Professor Ghia, who is a very well-known name in CLL. Prof. Ghia, just brief presentation about him because he will be having a long CV. He has his MD in the University of Toronto in Italy, and then he moved to Dana-Farber Cancer Institute at Harvard Medical School in Boston, where he studied the molecular mechanism of the pathogenesis of chronic lymphoproliferative disorder, particularly follicular lymphoma. He is now working in Milano as a professor of medical oncology at the University Vita Satu San Rafael, and he is the deputy chairman in the Division of Experimental Oncology at Hospital San Rafael. He has published over 260 manuscripts in peer-reviewed journals, and he is the president of the European Research Initiative on CLL, collaborating to the guideline for the detection of MRD. He is also a member of the International Workshop on CLL and of the WHO Clinical Advisory Committee for lymphocytic and histiocytic malignancy. He's a co-author of EHA and Acmg Guidelines for CLL treatment. And as I mentioned, very long CV, so just a brief presentation. Dr. Ghia will present a new horizon on CLL management. Prof, the floor is yours, please.
Yes, thank you very much for your presentation, and I'm just showing my slides. Thank you also for the invitation to be here with you. Unfortunately, again, once more virtually, but it seems, let's be optimistic, it seems that maybe the next few weeks or months will look better for all of us. So new advances in CLL, I will take advantage of the recent ASH Congress in Atlanta in 2021. I just want to remind you that here that the presentation is supported by Janssen, but all what I'm going to say is my personal opinion, and these are my disclosure also to show how dynamic is the field of CLL research, and new drugs are continuously coming in the field, and they are improving the way how we manage our patients. And as I said, coming back from ASH, we really got the impression that we are close to that moment in which to decide the treatment for a patient with CLL is becoming somehow difficult. It's not anymore 1, 2 drugs, but we are really to understand on one side how the disease is in each single patient. So we have to do a genetic stratification. We know since a long time now the value, the predictive value of the immunoglobulin gene status or the p53 status, and that has to be defined in all patients before starting a treatment. And then on the other side, we have also to know very well the patient himself or herself, and because of the comorbidities, the age, the fitness of each patient, and then we have to combine this with the information and the knowledge that we have on each single drug. And then, of course, having more options, it makes the market more difficult also for the patient. So the patient has started to having a saying in this, so the patient preference is indeed entering the picture of the decision. And as mentioned and anticipated, here I've been co-author in the Acmg Guidelines, and here we really see what I just meant, what I just said. So the first level of stratification is really the genetic assessment of our patients. mutated or unmutated immunoglobulin genes, p53 mutations or deletions. So we have to test for FISH and the sequencing of the gene, so two different tests. And then afterwards, we have to take into consideration age and fitness of the patient. And then we have this plethora of treatment, combination of treatment, as we say, as we see in a few minutes, that really will make somehow the decision of how to treat the patient difficult. So what we learn, so we start from the basic, I would say. So what we learn and confirm, and we presented the data at EHA in June, is that BTK inhibition is a main pillar, and I would say a crucial pillar of the treatment of patients with chronic lymphocytic leukemia. And here indeed we showed that the follow-up is 7 years, where elderly patients were either treated with ibrutinib or chlorambucil. We are not interested in looking at the chlorambucil arm, but here the interesting data is that at 7 years, with the median PFS, progression-free survival, has not been yet reached. So 61% of the patients are still not progressing after 6.5 years. So that will prolong further the median PFS for this patient. So somehow, especially in the elderly, we are really reassured that we can control for a long time the disease. And this is true also for mutated and unmutated patients, as you can see here at the bottom left. So there is no more any difference in terms of prognostication or predictive power for the immunoglobulin when we use ibrutinib. And the last but not less interesting point is that if the patient remains on therapy, because this is, as you know, a continuous therapy for 7 years, then you can get a better response. So the drug is continuously working, deepening the quality of the response. So more than a third of the patient will achieve complete response, which, as we know, difficult to obtain. The same thing is true for patients with p53 aberration, which we knew that they are the most difficult patients to be treated. They should never be exposed to immunochemotherapy. And again, with continuous treatment, continuous inhibition of the BTK pathway, then we obtain results that are similar, if not identical, to all the remaining patients. So on the left side, we look at the pooled analysis of 4 different studies, 4 years of follow-up. Only the patients with deletion 17p and or p53 mutation have been considered. 79%, so 4 out of 5 patients are still progression-free after 4 years. And even in this particular subgroup of patients, we have long-term data from Adrian Wisner, the study, a phase 2 study at NIH. Patients in first line have been treated with mutation in p53 or deletion 17p, have been treated with ibrutinib, and again, 6 years, 61%. So very similar to what we have seen in the RESONATE-2 in the normal patient population. If we look at 4 years time point, 79%. So completely different study, but the results are very similar. So really reassuring on the robustness and durability of this response. At ASH, we had the possibility, and Jennifer Voyak presented the update of the Alliance study. This is a different population, still elderly patients who can be treated with bendamustine plus rituximab, which was the standard arm, so a little bit fitter than the patient in the RESONATE-2 study. Compared again to ibrutinib plus minus rituximab, we already know that the addition of rituximab does not really change anything in terms of progression-free survival. But again, with a longer follow-up, we are talking now about 55 months, so we are well beyond 4 years of follow-up. The advantage with the benefit with the ibrutinib-based treatment is really dramatic compared to bendamustine plus rituximab, first-line elderly fit patients. And the same thing is true for patients with p53 aberration that, of course, should never be exposed to immunochemotherapy. If you look at the patients with unmutated immunoglobulin genes, you see a dramatic benefit when using ibrutinib-based treatment. With patients with mutated immunoglobulin genes, there the advantage is much less relevant as we expect, but we know also that mutated patients are those who are less prone to receive treatment. Similar story if we even look at the younger fit patient. Again, another study presented at ASH. Peter Hillman presented the FLAIR study, ibrutinib plus rituximab again versus FCR, fludarabine, cyclophosphamide, and rituximab. So we are talking about young fit patient who can tolerate FCR. And the PFS, again, it's in favor of ibrutinib, not yet reached with ibrutinib, is 66.5% for FCR when we look at the follow-up of, again, well beyond 4 years. We know that with FCR we obtain more complete responses, we get more undetectable MRD than with ibrutinib, but that really does not translate into the disadvantage, rather the opposite. So even if we don't reach complete responses, even if we don't reach undetectable MRD, the continuous pressure on the clone will translate into a long-term benefit. In the FLAIR study, the same information about immunoglobulin gene status is evident. So patients with unmutated immunoglobulin genes have a great benefit when they are treated with ibrutinib, even compared to FCR, which is the most potent immunochemotherapy. And this advantage is disappears when we look at the mutated patient, where we know that both options can be good as good. And of course, here we have to discuss with the patient, and here the patient preference comes into the play. We have to discuss about fixed duration, 6 months with chemotherapy, continuous treatment with ibrutinib. But on the other side, as we see here, the patient treated with FCR may have long-term disadvantages like acute leukemias, MDS, or risk of infection that can last for up to 2 years after FCR. Of course, with ibrutinib, we know that we have a number of adverse events, because even if it is better tolerated and all the novel therapies are really an advancement in terms of tolerability compared to immunochemotherapy, but still they have their adverse events, which are mainly on the cardiac side for ibrutinib. But I just want also to draw your attention on the fact that we are typically talking about a population that is made of elderly individuals, and in particular with other comorbidities. So this is interesting when we look at the CLL-12 study, a study by the German CLL study group, where ibrutinib was compared to a placebo in a population who did not need the treatment, but it was treated in a preemptive way. And what we saw with a lot of interest is that if you look at adverse events, exactly the same percentage of patients complain about an adverse event in the ibrutinib and placebo arm. So even in the placebo arm, patients were having adverse events. And so really, we have to remember that the population that we are managing is indeed made of elderly, comorbid patients, so they might have many other issues that are not to be referred to the drug itself. So we have always to remember that most of the time it's easy to say it's because of the drug, discontinue the drug, and then the adverse event doesn't go away. On the other side, the major adverse event we know with ibrutinib is bleeding, but it's minor. Vast majority of cases it's minor bleeding. It really doesn't affect the quality of life of the patient, and it tends to disappear and fade away with time. Major hemorrhage may exist, and this is a problem with all the BTK inhibitors, even the second generation BTK inhibitors, and it's in a fairly rare population of patients, and only in 1% of the cases is really leading to discontinuation. It's a cause, it's a reason to discontinue ibrutinib. In other cases, even if they had major hemorrhage, you might stop it for a bit, and then you can reintroduce it. The other issue that we all know is atrial fibrillation. I think that what we learned in the past 5, 6, 7 years is that really you have to start a tight relationship with a cardio-oncologist, which is really helpful because it will really reassure you on the fact that atrial fibrillation is not a major clinical issue. Of course, you have to treat the patient, you have to manage the patient accordingly, but you can start also anticoagulation therapy if it is needed. Not every patient needs it. That's something I learned from my cardio-oncologist. And the other issue relevant is that this higher risk is particularly high in the first 6 months, where you have indeed to keep an eye on the appearance of atrial fibrillation. Then later on, the risk is really decreasing a lot, and it will remain there, but also because, again, the patients are getting old, so it is, I would say, physiological or associated to aging, the fact that they could develop atrial fibrillation. So having said that, as I said, ibrutinib, the continuous treatment with BTK inhibitors is really a main and crucial pillar of the treatment of patients with chronic lymphocytic leukemia, and in many instances remains the best option we have. So I'm thinking about particularly elderly patients, where you can give your 3 pills a day, and you don't need to follow the patient closely. They can come back after 2 or 3 months for the visit, and we know, we inform the patient up front of what can happen in case they feel they have atrial fibrillation. They have to be referred to the hospital, and all the other cases they can stay away. They don't need to be hospitalized. They don't need to do infusions. They don't need really inpatient care. In the elderly, as I said, it's probably the easiest option we have. Of course, when we talk about younger patients, the fixed duration treatment is an attractive option. So, of course, you don't want to bind the patient, young patient in the 50s to a lifelong therapy. Even if, as I always say to my patients, if the drug will work for all your life, I mean, you should consider yourself very lucky, because it means that with one drug you can control it forever. But the fixed duration is, of course, a goal that we all want to obtain now that we have good drugs and we know that they work very well. We want to define a limited amount of drug that is sufficient to keep control of the disease. And that's why a number of studies developed the idea of the fixed duration treatment. And of course, thinking about the fixed duration treatment, the best partner with ibrutinib is the BCL2 inhibitors, in particular venetoclax, that is the only one at the moment approved. And that makes sense for the simple reason that ibrutinib is, as we know, very good in stopping the proliferation of the cells and mobilizing the cells from the tissue, the lymph node, the bone marrow, where they are really making damages, and they are the reason of anemia, thrombocytopenia, and large lymph nodes. Then they are mobilized into the peripheral blood, where the cells become much more prone to die, even alone, but in particular if exposed, of course, to a pro-apoptotic agent like venetoclax. So that will help somehow synergistically to eliminate both the proliferating cells in tissues and the resting cells that are mobilized into the peripheral blood. And that has been translated into a number of studies. Here I show you the Captivate study that I presented at ASH a couple of months ago, where a patient with chronic lymphocytic leukemia at the time of first treatment had been treated with 3 cycles of ibrutinib as a lead-in, so to debulk the patient, and then 12 cycles of 12 months of ibrutinib plus venetoclax. The study has 2 different cohorts, which are not randomized to each other. So one is the MRD cohort, where patients at the end of the 12 cycles were tested for the MRD levels, and those and were randomized based on those levels. So those with undetectable MRD have been randomized to discontinue the treatment, so placebo, or continue ibrutinib, which we can consider somehow a standard treatment. On the other side, those who did not achieve undetectable MRD, they were randomized to continue a therapy, either single monotherapy, ibrutinib, or the combination of both drugs, ibrutinib plus venetoclax. After seeing these results, we started another cohort, so-called fixed duration cohort, exactly the same treatment, but every patient stopped at the end of the treatment, because we had some hints that the potency, the power of this combination was really dramatic in every patient, regardless maybe of the MRD level. Anyhow, these are the results in the MRD cohort. So the first cohort at the end of the 12 cycles, roughly 3/4 of the patients obtain undetectable MRD in the peripheral blood. It's very similar in the bone marrow. I just want to show you that this was all-comer study, so every patient with CLL could be enrolled. And though, I mean, roughly 1 out of 5 patients had a p53 abnormality, and 60%, so almost 2/3 of the patients had unmutated immunoglobulin genes, another 20 with complex karyotype. So the population is really mirroring, resembling what we see in first line in our office, and probably it's even a little bit more than that. So with a very 20% of patients with the p53 abnormality, which is very high, typically it's between 5 to 15%. So really suggesting that there was a lot of hope in this combination, and therefore a lot of high-risk patients have been enrolled in this study. And the data and the results are very interesting. These are the one I presented at ASH this year, or last year, 2021. So this was the updated analysis of 2-year disease-free survival. Disease-free survival is a little bit different than progression-free survival, because disease-free survival, it means that the patient is free of disease progression, of death, but also of MRD progression. As you can see here, there has been no event in the last year. So since the 1-year disease-free survival data that we presented in 2020, in 2021, 2 years disease-free survival remain exactly identical. And we are in both arms more than 95% with 2 years after end of treatment had no event. The interesting point is that there is no significant difference between the two. So we can say that in a patient with undetectable MRD, we can safely discontinue this therapy, and at least with 2 years of follow-up, we can have the same result as continuing ibrutinib forever. Then we have also the patients who did not achieve undetectable MRD, and we looked at the PFS. In this case, traditional PFS, progression-free survival, we have 3 years from the start of the treatment, and as you can see here, again, also in terms of progression-free survival, at 3 years, no differences between ibrutinib and placebo in the patient who achieved undetectable MRD, but also if we look at those who did not achieve undetectable MRD and they continued ibrutinib or ibrutinib plus venetoclax, again, a very high number, more than 95%. So the overwhelming majority of patients have 2-3 years that is free of any event, with 12 months of treatment. And the interesting point I want to make here is that probably we talked about fixed duration, so 1 year equal for everyone. Maybe this is not going to be the case in the future, because if we look at the patients who did not achieve undetectable MRD and they continue treatment, those who received ibrutinib plus venetoclax, they were able to increase the number and the frequency of undetectable MRD. So somehow suggesting that maybe we should really use undetectable MRD as a way to achieve deeper responses in those patients who do not achieve undetectable MRD in the first year. Then we can add an extra year, and we can really increase the number of these patients. And interesting enough also is that all these results, very interesting, I think, definitely very new results can be obtained with very little toxicity in addition. And indeed, only diarrhea is the only adverse event that is higher than expected with a single drug, either ibrutinib or venetoclax, that are both can be responsible of mild diarrhea. All the others are exactly in the range that we expect for the single for the monotherapy. For example, like neutropenia. And the interesting point I also want to make is that, for example, if you look at arthralgia, this is the placebo arm, and these are the treated patient arm, and you can see that the numbers are very similar, if not identical. Again, we have to remember that patients may have arthralgia for any reason because they are getting old, so it's not always because of the drug. Here I show you the SD cohort, fixed duration cohort, that and the paper has been, we presented at ASCO, but the paper has been accepted exactly today. So I just received the email, and in blood. And again, in the fixed duration, everyone stopped the treatment after the 12 month. Complete responses more than 54%. We don't really care about that because we know that undetectable MRD are much more frequent. Again, 3/4 in the peripheral blood, maybe here 2/3 in the bone marrow. We don't really know the reason why, because the treatment has been exactly the same. But the point here that we understood is that all patients, and this is a 2-year progression-free survival, all patients, regardless being having achieved undetectable MRD or not, they are still there, more than 95%, 96%, the one without deletion 17p, are still not progressing. So somehow we understood from this cohort that it's true that with following MRD, we can really personalize the treatment, but probably we don't need it. Because all patients, even those with the detectable MRD, after 2 years, they are still not progressing, and they are exactly on the same curve. The other point is, of course, as you would ask, and we are all asking and waiting for longer follow-up, is what happens in those few patients who progress. And here I just show you in a table all patients who progressed after fixed duration. So those who were in the MRD cohort and entered the placebo arm, who had to discontinue the treatment, or those who were in the fixed duration cohort where everybody stopped. So we are talking about 12 patients for which we have data on 9 patients, so really very few. But still, these patients progressed after quite a long time, so meaning one was almost 1.5 years, but all the others were more than 2 years after stopping treatment. So this is, I think, a reasonable time. 1 year of treatment, 2 years or even more free of disease, and then you need again treatment, which is fine. I mean, you are really giving a treatment holiday. Everybody responded with ibrutinib, as you would expect, because 1 year of treatment is not gonna give any resistance to the drug. And if we look at the genetic features, there is not really a story here. So some had deletion 17p, some had complex serotype, some had unmutated immunoglobulin genes, but half of them had mutated immunoglobulin genes. So it's probably we need more research to get to know predictive factors that can help us to decide, to know upfront who will probably progress. So I move now, I'm going to close my talk with the GLOW study. Again, the update is being presented at ASH 2021, where the same combination, ibrutinib plus venetoclax, has been compared to chlorambucil plus obinutuzumab. So we are talking about elderly comorbid patients, and this is a registrational study, it's a phase 3 study. And again, no surprise, the combination I plus V is much better than chlorambucil plus obinutuzumab. We had probably no doubts, but this was requested by FDA for approval. And again, the same story, the better PFS is also due to, very likely to a higher frequency of undetectable MRD, and in particular, even very deep undetectable MRD, so below the level of 10 to the minus 5, which is much lower than the 10 to the minus 4, which is the standard undetectable MRD. But the point I want to make here, following also what we saw in the Captivate study, is that, of course, the patients who achieve undetectable MRD with ibrutinib plus venetoclax tend to remain much longer in the undetectable MRD status compared to chlorambucil plus obinutuzumab. We know that's expected. But interesting point is that even the patients who did not achieve undetectable MRD, they do not really progress. So they do not really, the levels are not really moving and progressing with time. And again, giving the impression that we had also in the captivated, somehow the patient treated with this combination, regardless the level, they are probably because of modification of the natural history, they always, sorry, apologies. They achieve a benefit regardless achieving the fact that they achieve undetectable MRD. And therefore, you can see it also here that patients with or without undetectable MRD treated with the combination have a very similar and very prolonged progression-free survival, much better even the patients who achieves undetectable MRD with immunochemotherapy. So this is something that we have to keep in mind, for which we are a little bit struggling because it's counterintuitive, but that's why we were also keen on doing the fixed duration cohort in the captivate study. With this, I conclude, and I thank you for your attention. And as I said, the future of treatment CLL is becoming maybe more complicated, more interesting, definitely, and new options like the combination is probably going to be very helpful for many, many patients. Thank you very much for your attention.
Thank you, Prof. Thanks for being on time. So we'll have questions. This is a satellite symposium. Any questions? Yes, Dr. Said.
Thank you for a nice presentation. With the updated data now from the Captivate and GLOW study, do you think now the objective of having MRD negative in CLL in routine practice or in coming studies might be less likely to be a primary objective?
That's a very good question. I have to say that I did a lot of work on MRD, so I'm even sorry to say, but it's probably true that unexpectedly, with this combination, the undetectable MRD level are not really predicting your future, because even those with undetectable MRD, they are really maintaining the response for 2-3 years. So that's what we are learning, and so it's an ongoing process of education also for us. And so we learned that, and that's why we designed the study in a different way, because probably we are not going to need undetectable MRD. Maybe, again, the only thing would be that those who do not achieve undetectable MRD, maybe you want to prolong a little bit longer the treatment, but again, the GLOW study doesn't tell that to us. 1 year, it looks to be very good for everyone. The real challenge will be to identify upfront those few, because are really few, like 5-10% of patients who will have a shorter duration of response.
Any more questions? Yes, Doctor, please. Yeah. One more.
Thank you again. I want to add, for those who progressed early after protinib and venetoclax, although they didn't develop resistance most likely, but they proved that fixed duration maybe is not a good option for them. So maybe the subsequent treatment should be lifelong. Do you think so?
Yes, definitely. That's a very good remark. And we have a study here in Italy, we just finished it, where indeed we are doing exactly like that. So somehow the use of the combination is a readout to sort out those few patients who do not benefit from a fixed duration treatment. So some patients, even in the future, will need to be treated continuously, because that's the only effective way to treat them. And in this way, we can find them somehow. And with 1 year treatment of ibrutinib, we know that we are not giving resistance, so we can really restart after 1, 2, or 3 years, knowing that the efficacy will be exactly as before. So that's a very good point. Let's use that really as a screening test, I would say.
So for the sake of the time, thanks, Prof. Faria. By that, we'll conclude the satellite symposium, and we'll start the next talk. Dr. Ibrahim, would you mind to present the second speaker?
Assalamu alaikum. course, thank you for the committee. Very nice meeting. And this is my pleasure to introduce Dr. Radhui from Associate Professor in University in Oman. Dr. Radhui is well known in our area for being active in the field of hematology. He's trained in Canada, internal medicine, hematology, and bone marrow transplant. His talk will be about MPN, the Oman experience. So please, Dr. Mustafa. Thank you.
Assalamu alaikum, everyone. Thank you, Dr. Ibrahim, for the introduction. And I would like to thank the organizers for the invitation. My talk today for the next 20 minutes would be about the MPNs, the Omani experience. In this talk, it would have two short parts. One is to highlight the familial aspects of MPN in Oman, and I'm sure in the region. And I'm just propose very briefly how we can research this, and then explain the different MPN phenotypes despite the same driver mutation, the JAK2. It's a study that we've tried to explain these different phenotypes. So I would start with the presentation of one family. I had a patient who's 72 years old male who presented with pancytopenia. He had massive splenomegaly, and his bone marrow biopsy showed advanced collagen fibrosis. He harbored JAK2 B617 F mutation, and his final diagnosis was MPN. The subclass was primary myelofibrosis. Unfortunately, he had significant pancytopenia. We could not start him on ruxolitinib. That was maybe a few years ago. And he underwent splenectomy. He had a complication of major bleeding after splenectomy, and unfortunately he died with sepsis a few days after splenectomy. Now, a few years after that, I got a referral from a hepatologist. And that patient turned to be the son of my old patient. This is a 36 years old referred from a hepatologist with chronic liver disease and portal hypertension. He had large spleen, and he was saying his spleen is out of proportion of what would I expect for a portal hypertension. Despite having normal counts, he just told him that my father had this, and then he referred him to us. What we did, actually, we started with the molecular testing, and he was JAK2 positive, the same mutation that his father had. And then went and did a bone marrow biopsy, which revealed fibrosis, grade 2+. So his diagnosis was primary myelofibrosis. Now, this presentation is the well-documented presentation for the familial MPNs in literature. If you look at the literature, and you took one of the large study there, they presented a number of families, including those 4 families. And as you can see, that the phenotype that they have, let's say in the earlier generation, PV, is the same phenotype that later generation gets PV. In family 1, in family 2, and the example here is ET, and in family 3, the example is myelofibrosis. In family 4, PV, and the later generation showed myelofibrosis, but this could be post-PV myelofibrosis, and it is difficult to ascertain. Now, this is the classical description of MPN, what our case had. I'm sure you've seen in the region in Saudi and in the region similar cases. However, we do also see a different phenotype than what is reported in literature. So this is another family, a 48 years old male with anemia. He had massive splenomegaly, and his bone marrow biopsy showed grade 3 plus fibrosis. He had JAK2 positive, and his final diagnosis was primary myelofibrosis. After actually 2 years of his follow-up, He told me that I have an older brother who has been treated somewhere else, and he came recently to the country. So I asked him to bring his brother, and his brother was 52. Again, exactly the same presentation: anemia, massive splenomegaly. He had more advanced fibrosis, almost the same fibrosis, actually 3 plus. However, the interesting part that he did not have JAK2 mutation, he had CARL mutation. And his final diagnosis was again primary myelofibrosis. So this is a different phenotype where the phenotype is the same. However, the mutation, the driver mutation is different. We tested both of them. We tested this one for CARL and JAK2, and we tested that his sibling as well for CARL and JAK2. So they probably have something before JAK or CARL that predisposes one to JAK and the other one to CARL. So that's another difference that is not really described in literature that we see here. The other phenotype that we see here is not well described in literature, is illustrated by this family 3. This is a 38-year-old female with leukocytosis, classical presentation of CML, BCR-ABL. We see her, and after a few visits, she brings her mother, and she told me that her mother has been treated multiple times with antibiotics because her white count is high. So we tested her mother. She had mild leukocytosis, and she was negative for all the classical mutations that we could test: the BCR-ABL, JAK2, CARL, and MPL. We went and did a bone marrow which showed pre-fibrotic stage of primary myelofibrosis. So this CML with a mother having unclassified or maybe pre-fibrotic myelofibrosis. So this is again not well described in literature. So that illustrates that we do need to investigate this area. One way to investigate it is to follow what the steps of genetic epidemiology. And here I would list the steps in genetic epidemiology and maybe highlight some of the areas that we could research. The first step in the genetic epidemiology is description of disease characteristics, which is, if you look at the literature, it is full, like worldwide and also from our region, and I'm sure from different countries. So this is descriptive epidemiology. The second part is demonstration of the familial clustering. And the way you do that, you take all your MPNs and you see how many familial clustering, cases clustering in different families. This is also being done in literature. And if you look at the MPN, it ranges between maybe 7 to 8% of patients with MPN would have a strong family history of an MPN. So this is, again, described. What is also described is the relative risk. So a relative risk here is an estimate of how strong is the gene component, the driver of the gene driver. So if you have high relative risk, that means there is probably like a driver, really a strong driver. If you have a strong, if you have a low or a small relative risk, then you have maybe a mild driver here. And if you look at the MPNs, specifically the non-CML, the PV, ET, and myelofibrosis, the relative risk is in the range of 7 and 8. That is that the risk of having an MPN, if you have a sibling with MPN, compared to the population risk is 8 times, which suggests that there is a strong, probably a strong driver there. If you look at the CML, the difference is significant. The relative risk there is about 2, while there is about, while in MPN, that is non-CML, is about 8. So this is probably is needed that we should do it here because we may have a different genetic predisposition with a stronger relative risk. The second question, the second step, or the next step in genetic epidemiology is to ask whether this familial clustering is because of the environment. Families most of the time live together, or no, it is a genetic driver. Here, to illustrate this, you will need specific designs in that regard. Twin, adoption, half-sibling, migrant studies that would tell you whether that relative risk is because of a genetic component or an environmental component. This is, again, definitely not done in our region, but may be done to some extent internationally. The next is mode of inheritance. And you illustrate this by doing a segregation analysis. You just draw the family pedigrees, and through this, you demonstrate whether this is a dominant or a recessive, X-linked, or other, or a polygenic. The next step, after you demonstrated that there is a genetic component, you need to identify the region, identify the gene. And you do that by linkage analysis. Again, linkage analysis here is not well studied in the MPN literature. The mutations that have been described with the susceptibility loci research goes again to the JAK2, CAL, maybe retinoblastomas gene. But this is again an area that we could also study. The last part is the disease susceptibility markers. Okay, we know the gene, but is there, where is it in the gene? What is the allele? What is the marker? And for this, you need to do association studies. And classically, association studies states, specifically if you went with whole genome, like a genomic approach, then you will need a very large sample size. And this is definitely, it will need a collaboration from that region. So this is the first part, the familial component, the familial aspects of MPNs in Oman, and I'm sure also in the region. The second part of my presentation today is an attempt, a study, to try to explain why a single driver mutation, JAK2, gives you different phenotypes, PV, ET, and myelofibrosis, or even unclassified. So if you look at the MPN and you do a bone marrow, you would see either a panmyelosis, which suggests the PV, megakaryocyte proliferation, which suggests essential thrombocythemia, or advanced fibrosis or megakaryocyte proliferation with granulocyte proliferation, which suggests myelofibrosis, either fibrotic MF or prefibrotic MF. And you look at the driver mutation, predominantly JAK2 in PV, more than half in ET, and more than half in MF. So again, a single driver mutation, JAK2, gives you different phenotype. What is the reason? So here, maybe we hypothesize that it may be the epigenetics that drives the phenotype. So you have a JAK2, but you have different epigenetics, mutations, or different phosphorylation that can explain the different phenotypes. So what we did, we did a study that included patients with JAK2 positive MPN, only JAK2 positive MPN, only for adults, and between the two major hospitals in Oman. So we captured most of the MPN patients diagnosed in Oman. The study was retrospective, but the molecular testing was done on diagnostic samples that we kept for those patients. Now, this is overall a small study, and most of the analyses are more of exploratory analysis rather than hypothesis, more of hypothesis generation than hypothesis testing. So we went into these genes, the modifiers of the epigenetics, the AXL1 and 2, DNMT3A, EZH2, IDH2, TET1, and TET2. Later, our molecular biologists added two other mutations, but we sequenced the entire coding region of those genes. Unsupervised cluster analysis was done. We used ion torrent next generation sequencing for sequencing. And then we've identified the variants, and we've tried to classify the variants either based on the ClinVar database, based on the clinical information, or if we did not find the clinical information there, we went with other tools of the SIPT and Polyphen2 tools that could use computer prediction, in silico prediction of whether this variant is pathogenic or not. We had a total of 61 patients. Almost half of the patients were PD. The other half were ET and myelofibrosis. The median age of presentation was 62 years. As expected, more males. Half of the patient had splenomegaly, and maybe 1/4 of the patient had thrombosis at presentation. Now, this is the classical findings in CBC. It is also important to mention that the median erythropoietin level was 1.2 with a range of 1 to 4.8. So fairly suppressed erythropoietin. The first part is the heat map. So with this heat map, these are the variants that we found before the classification, whether they're pathogenic or not. We kind of included all the variants. And here are the number of samples. And as you can see in the heat map, there is no specific pattern from that heat map that would cluster the samples or the variants. Maybe with the variants on the rightmost, they are different for almost all of the samples. So there is no specific pattern in our heat map that could help us correlate it with the phenotype. Then the clustering. Here with the clustering, we see two major clusters and two subcluster in one of the major clusters. Again, although the clustering was done and the system was able to give us a dendrogram, but when you try to superimpose the subtype, the MPN phenotype, it does not really correlate well. So now using unclassified variants and unsupervised clustering methodology, we could not use the epigenetics information into the explanation of the phenotypes in MPNs. So the next step is maybe we said the frequencies, the load of the variants may be important. And on a median, 13 variants were found per patient. That ranged from 11 to 14. So relatively large number of variants. And as you can see, most of the variants were found in the classical genes that have been associated in the clonal hematopoiesis in the elderly. So ASXL1, ASXL2, and TET1 and TET2. So most of the variants were found in these four genes. And then we tested whether that load could explain the different phenotypes.
Dr. Murtada, you have 2 minutes more only. 2 minutes.
Okay. It did not explain. The only difference is that those with a higher load showed significantly suppressed erythropoietin of 0.9 versus 7.6. Now, in terms of the load, it did not. And this is what we said, maybe let's only select the variants at the pathogenic variants. And we had almost 8 pathogenic variants that we could classify from either ClinVar or the in silico prediction, and with the MAF, with the mean allele frequency of more than 5%. Now, this is a little bit complicated and busy. Here is the genes. Here are the genes that we tested, and the different colors of the bars are the different phenotypes. The size of the bar illustrates the p-value. So it is a similar concept to Manhattan plot. And here what you want shorter bars, hopefully less than 0.05, that would try to explain the it would be statistically significant. And as you can see here, that there are few findings in TET2, mostly actually in TET2, that would correlate it with the white cell count, LDH, and maybe erythropoietin. But it still did not correlate with the phenotypes. So the conclusion of this study that mutation load is not associated with MPN subtypes, though it did correlate with the EPO level. Mutation profile is not associated with the MPN subtypes. Incorporation of the clinical information did facilitate some of the prioritization of the variants from the DNA sequencing experiments. We did find few variants that did correlate with some of the clinical information, though there is an issue of multiple testing, specifically in this small study. The other major limitation is the study was retrospective. Now with that, I would like to thank whoever contributed to the different aspect of this study. And I would like to thank you for listening and the organization for the invitation. Thank you very much.
Thank you, Dr. Murtada. We'll leave the question to the end of the session, if you don't mind. So we'll move to the next talk, which will be presented by Dr. Tanweer Katalani. Dr. Tanweer is a professor, has his PhD in molecular biology and immunology at Yamaguchi, Japan. He did his postdoctoral training at MD Anderson in Texas. And then he moved to Chicago, where he did his comprehensive cancer training in the research. And before moving to Riyadh, Dr. Katalani worked as a senior researcher at Baylor College of Medicine in Houston. And currently, he is a research scientist in the Department of Cell Therapy and Cancer Research at KMARC in Riyadh, and he has published more than 45 original research articles. He has a special interest in thrombosis, and he did a lot of studies and the research in platelets aggregation, atherosclerosis, and thrombus formation. Dr. Katalani will speak about human placental mesenchymal cell, stromal cells that inhibition against induced platelet function, reducing atherosclerosis and thrombosis phenotype. Yes,
good afternoon, everybody. And I would like to thank SSBMT and SSH for giving me the chance to present my work here today. So my presentation is a little bit, as you see, is a little bit different from whatever we have been hearing since yesterday. It is a pure. So it is a little bit different from whatever we have been hearing since yesterday. It is mostly lab-based study, the basic study, the basic science study. So I hope that you enjoy it. Thank you. So my talk, the topic of my talk is the consequences of interaction between placental mesenchymal stem cells and the platelets. So I will give some background information followed by introduction of the topic, and then I will discuss about the objectives, results, and finally the conclusions. Mesenchymal stem cells. We all know that mesenchymal stem cells are MSCs. They are multipotent adult cells, adult stem cells, which have the property to differentiate into adipocytes, chondrocytes, and osteocytes. They can differentiate also into other stem cells that include the neurons, cardiac cells, muscle cells, and other cell types. So they are isolated almost from all other adult tissues, but the most common ones are adipose, dental polyp, bone marrow, umbilical cord, as well as the placenta. So MSCs possess immunomodulatory properties. They have immunosuppressive properties. They have differentiation potential. They have tissue regeneration potential, and they have the ability to home to the sites of inflammation. And because of those properties, they are used in cell-based therapies, including cancer, cardiovascular diseases, immunological disorders, and diabetes, etc. So in cell-based therapies, they have been used as intact cells for therapeutic purposes, or their cellular product have also been used for for therapeutic purposes that include the exosomes or conditioning media we also call a secretome. So although they are the excellent sources for cell-based therapy, but still in humans and in animal studies, rare and minor adverse events have also been documented in MSC applications. So in animals, we have seen increased death rates, which have been seen because of the thromboembolic events after infusion of these MSCs. These thromboembolic events may occur through different mechanisms. They include the size of the cell, size of some of MSCs, which may get trapped and occlude small vessels in lung capillaries. And also, the other mechanism is that some of these MSCs, they promote coagulation through high expression of procoagulant molecules, which trigger the clotting cascade. So we have been working on, for a while, on placenta-derived stem cells. From now, I call them as PMSCs. So we have isolated and characterized 3 types of PMSCs from human term placenta. That includes the DBMSCs, or deciduous basalis mesenchymal stem cells. They are isolated from the maternal region of human term placenta. DPMSCs are deciduous paratilis. That is also from the junction of maternal and fetal side of human term placenta, and also chorionic villus MSCs or CVMSCs. They are isolated from the fetal region or villus region of human term placenta. So why placenta? Why did I choose placenta for isolation of MSCs? So because placenta, as all of us know, is a waste product, it is discarded eventually after the birth of the baby. So although we have to get the informed consent from the patients, but still it is generally devoid of major ethical considerations. And unlike other tissue collection, these we don't have to use any invasive procedures. So we have to use the tissue is collected from non-invasive procedures. And it is a rich source of stem cells, and we get substantial number of placenta from a small piece of tissue. And also, as like other MSCs, PMSCs are immune modulators. They have the broader differentiation potential, and they have limited proliferative potential because we can grow them only up to maybe 5 or 6 passages. After that, they either differentiate, shed, or die. So they grow on plastic also, and because of their limited proliferative potential, they have low risk of teratoma formation post-transplantation. And as compared to other MSCs, like bone marrow MSCs, they are smaller in size, therefore no occlusion or little occlusion was found in lung vessels in animal models. So we undertook this study because of the immunomodulatory properties. They make them excellent sources for cell-based therapy against immune-mediated diseases. And they also secrete soluble factors that exert immune responses on multiple cell lineages like T cells, B cells, NK cells, monocytes, etc. So we hypothesized that they may interact with platelets also and modulate their functions, and in turn play a role in atherosclerosis and thrombosis phenotypes. So the aims of this study was to see the effect of PMSCs on platelet activation in presence and absence of various agonists, and to investigate if PMSCs modulate platelet functions, playing a role in platelet-mediated thrombosis and atherosclerosis. So we isolated platelets, we washed them, and treated them with the cellular component as well as the secretome of PMSEs. The cellular component was used as different ratios as well as the secretome at different concentrations. So platelets were stimulated using different agonists after treatment with the PMSEs and their secretome. And we used different agonists, including collagen, ADP, as well as thromboxane A2 inhibitor, U46619. And the effects of PMSEs and their spinnergians on platelets was evaluated by flow cytometry for the expression of activation markers and by platelet functional analysis. So we used human HUVEX as the control. So just a small just recap of the platelet activation and functions. Usually these the agonists, they include thrombin, ADP, CRP, whatever is it. So they bind to the receptors on the cellular surface, on the expressed on the platelets. And this binding just increases, this initiates an signaling cascade that on one side results in selection, the expression, surface expression of P-selectin, and on the other side, it activates the otherwise inactive integrin that's called as alpha-2b beta-3. So this is called as inside-out signaling. So this activated integrin alpha-2b beta-3 is recognized by an antibody that's called as PAC1. So this fibrinogen now binds to the activated form of integrin alpha-2b beta-3 and initiates the outside-in signaling that results in granule secretion, followed by amplification of platelet activation, stable adhesion, and spreading and aggregation, etc. So the platelets treated with different concentrations of conditioned media from DBMSCs at 5%, 10%, and 20% showed this, the dose-dependent decrease in P-selectin expression as compared to the untreated control. Here, the 10% and 20% treatment show significant decrease in expression as compared to 5%. The resting one did not, we didn't treat the resting ones. These are the resting platelets without any treatment. So we looked at the PAC1 expression also. It also showed a similar trend where 10% and 20% showed decrease in PAC1 expression as compared to 5% and the untreated controls. Similar trend was obtained with the DP MSCs from deciduous paratilis MSC conditioned media at 10% and 20%, where we can see the decrease in 5% also. There was significant decrease in PAC1 expression as compared to the controls, whereas in the PAC1 expression also showed decrease in the dose-dependent manner. However, for chorionic villus MSCs, we interestingly did not see any change here. We did not see any change here. There was no change in PAC1 expression after treatment with this conditioned media at 5%, 10%, and 20% after incubation with collagen at 2.5%, 2.5 microgram per ml. But as compared to untreated control, we did not see any change here. And similar trend was found in the PAC1 expression. Also, no change was found in the PAC1 expression. So next we looked at different ratios of the cellular component. This was the conditioned media. So now we look at cellular component at different cellular as 1:1, 1:2, and 1:5 cellular ratios. And in DBMSCs showed P-selectin levels decreasing significantly at 1:2 and 1:5 cellular ratios. And this is a resting one where we didn't see any change. Definitely, and in DPMSC treated, the cellular component treated platelets, we also see the change, the decrease in P-selectin levels at 1:1 and 1:5 cellular ratios. But as observed before, we did not see any much change. Although there is subtle decrease in P-selectin expression here, but it was not significantly, it was not statistically significant. So we looked at the PAC1 expression also of PMSC treated platelets, and as you see here, that DBMSCs showed a significant change, a significant decrease in PAC1 expression. DPMSCs also show a significant decrease, whereas CVMSCs did not show any change. So these are the resting platelets where we didn't see any change. So next, we looked at the platelet functions. That the first experiment that we did is platelet spreading on immobilized fibrinogen that was on this what's called glass coated cover slips. We put the platelets treated with different PMSCs as well as with agonists, and the unwashed, the unbound platelets were washed, and then the bound platelets were fixed and looked under the microscope. So we took as you can see here, this is untreated control, and we give the time points for 15 minutes and 30 minutes, and this is the treatment here. So when we quantify this and to look at the average surface area of the bound platelets, to look at the surface area of the spreading, so we see that here that DBMSCs and DPMSCs, again here, that decreases the surface area as compared to the untreated control. Although in CVMSCs also, they show decrease in the average surface area, but it was not significant between the two time points that we see here. After that, we looked at the adhesion. Adhesion is also like, it is a calorimetric assay where we see the binding and the adhesion of the platelets to the fibrinogen, to the immobilized fibrinogen in a 96-well plate. That's how we do, and we do the calorimetric assay where we look for the acid phosphatase release of the adhered platelets. So this is, so as you can see here, there is a percent adhesion there, 30 minutes and 60 minutes. Although in DBMSCs, we see significant change at 60 minutes. Although in 30 minutes also, we see there's an early event, we can see the change, but it is not significant. But in DPMSCs, as we can see that it is statistically significant at 30 minutes as well as at 60 minutes time for adhesion. Although in CVMSCs, we see some change, but it was not statistically significant. So after that, we looked at the aggregation studies of these treated platelets. So as you can see here, this aggregation was done, as we all know, this is just the electrical impedance that depends upon the turbidity of the sample. So it gives us the tracing in the machine. So because of the turbidity, as you can see here, the untreated control and CVMSCs show increased aggregation after 5 minutes, and as compared to the DPMSCs and DBMSCs, which show lower aggregation potential and lower aggregation the tracings here. So this was quantified, and you can see that DBMSCs and DPMSCs show decreased, significant decrease in aggregation, in total aggregation after 10 minutes. That is the total time that we take it for aggregation as compared to the untranslated controls. So, so after that, we looked at we did the mRNA analysis and looked at a couple of prothrombotic and antithrombotic genes that were expressed in these stem cells or these PMSCs. As shown here, we looked at antithrombotic genes like TFPA1 tissue factor pathway analysis inhibitor 1, protein C1, protein S1, serpin C, and thrombospondin 4. As you can see that they show higher expression in DBMSCs and DPMSCs. All of them are highly expressed here, except the certain, but they are highly expressed and statistically significant. So looking at the prothrombotic genes like VWF, GP6, phospholipase C, gamma, GRK5, and plaque strain, we see that they are definitely lower, showing low expression as compared to the HUVEX, and but interestingly, the CVMSCs showed higher expression of VWF as well as phospholipase C gamma as well as GRK5. So this expression, this mRNA expression was further verified by the protein levels of this prothrombotic and antithrombotic genes, and the upper panel shows the protein bands and lower panel shows the densitometry analysis of those bands. And this data corroborates whatever we get in the mRNA analysis. So platelet activation and atherosclerosis. So what is the relationship between platelet activation and atherosclerosis? Platelet activation and hyperactivity, we all know that it contributes towards pathogenesis of acute thrombotic disorders. So they play a central role in inflammation upon their interaction with leukocytes. And in addition, activated platelets also interact with lipids. It has been linked to thrombotic risk. So oxidized LDL mediated, oxidized LDL or oxidation of LDL promotes atherosclerosis. We all know that it through inflammatory and immunologic mechanisms that lead to formation of macrophage foam cells. And we have CD36, it is glycoprotein 4. It is a multi-ligand receptor that is expressed in macrophages, dendritic cells, and also in platelets. So these CD36, it recognizes certain oxidized phospholipids. So in platelets, CD36 binding leads to oxidized LDL that results in activation of specific signaling pathway that induces platelet hyperactivation. And this CD36 binding to oxidized LDL is believed to contribute the procoagulant state that is associated with hyperlipidemia and contribute to atherosclerosis. So we look at using the commercially available oxidized LDL kit. We did aggregation studies for all these PMSC treated platelets. And as you see here, as you see here, that the collagen plus oxidized LDL traces show high aggregation here, as well as we expected with collagen. But when they were treated with DBMSCs, either the conditioned media or the cells, this aggregation goes down, and that is what we have earlier found, that collagen plus DBMSCs showed lower aggregation of these platelets. And the quantification here shows that collagen plus oxidized LDL shows higher expression of higher aggregation here as compared to collagen only. But when it was treated with DBMSCs, so this significantly reduced the aggregation of platelets.
1 minute, doctor.
So so to conclude this, we show that a subset of PMSCs reduced activation of platelets, both via the direct contact as well as with secretome treatments. So decrease in platelet activation translated into diminished spreading, limited adhesion, and minimized aggregation. PMSCs also decreased oxidized LDL-induced CD36-mediated activation, establishing their protective role in atherosclerosis. And although PMSCs, they secrete this pro and they differentially express pro and antithrombotic proteins, which might be responsible for the activation of agonist-induced platelet functions, but we do not do any studies, so we don't know which proteins are responsible and what is the mechanism behind that. So these data suggest that PMSCs can be safely used for any disease setup, and we might not see any thrombosis or atherosclerosis phenotypes in those patients given those PMSEs. So I would like to thank my colleagues at KMARC. This is this cell therapy, this is stem cell and regenerative medicine at Cell Therapy and Cancer Research team. This is Dr. Yasir, Abdullah, Ireem, Dana. They are my technologists who conducted this study, and also this research proposal and processing department. They approved this study, and KMARC Research Funding Committee for funding this grant RC15. And KMARC operations for their logistical support, and also at Baylor College of Medicine. I am thankful to Dr. Subhashri Pradhan for conducting all the aggregation studies. Thank you very much.
Thank you, Doctor, for elegant presentation and research. So this time for questions. Dr. Murtada, you are with us?
Yes, Dr. Ahmed, I'm with you.
Can you stay, Doctor, for a question? You can come here. Dr. Murtada?
Yes, I'm available.
Thanks for this. So if I can have one question for you. Do you think this could work for inherited thrombophilia as well? It will help in the future? Or there is no studies done on those category of the patient?
As we know that we are the basic scientists, of course, we don't know, we have never done, but discussions are going on. I have talked to Dr. Askar, and he's very interested in that. He wants to continue the study in the familial, because he says that we have many patients there that have the problem, so we would like to do this study. But as I'm not a clinician, so I cannot comment on that. There is no study done. No, there is no study. At least I don't know. I have never seen any study like that.
I have a question to Dr. Tanvir.
Yes, thank you, Dr. Tanvir, for this excellent work. So what is the proposed mechanism of the MSCs in terms of inhibiting the aggregation?
Sorry.
The proposed mechanism, how this is really work in inhibiting the aggregation?
You mean the mechanism behind it?
Yeah.
Okay. So we are working on that. So right now we don't know whether some factors, because we are doing the proteome analysis, DNA analysis, looking at the factors, because you know that we have to go further deep to look at all the factors. They are secreted, all the factors they are expressed, because we see it in both conditions. So we hope that there are some factors that are expressed by these stem cells, and they are in the secretome. That is what we will analyze, that secretome. That is what we are going to do right now. We are doing microarray assays and proteome assays to see all the factors that might have any role. But this very in-depth study, that's what we are going on right now.
And have you conducted this in animal models?
Mice models, yes, definitely. That's, of course, that is our next part. And since unfortunately we don't have any animal house, otherwise we would have already started in Riyadh. But we have animal house in Hassa, and we will be soon going there to study that in animals, definitely. Yes, that's our next part, and it's already underway.
Any other further questions? Dr. Murtada, you are not with us anymore?
No, I am with you. Actually, I had a question to Dr. Tanvir, if possible.
Okay, so by that we'll conclude the session. If no more questions, thank you for the presentation.
Thank you very much, everybody.
Dr. Askar, you want a photo now or after? I think there is nobody. Maybe after the session. Thanks, everybody, for attending. Thank you, Doctor.
Thank you.
Thank you.
and he had his training mainly in King's College London, and he has more than 30 years of experience in adult hematology and bone marrow transplant at the Riyadh Armed Forces Hospital and King Faisal Hospital in Riyadh and King Khalid University Hospital. So he established the adult HSCT program in Dammam in 2010, and he has received several awards and has had more than 130 publications under his belt. So I invite you, and it is a pleasure for us to have Dr. Khalid here to discuss the HSCT experience for multiple myeloma patients in the Eastern region.
Thank you very much for the introduction. First, I'd like to thank the organizers for letting me have the honor of presenting the work of my colleagues at King Fahd Specialist Hospital. So, agenda of my presentation, first a brief introduction, then, well, basic literature on cryopreservation versus non-cryopreservation, and some historic data, then data of the patients with multiple myeloma who have received auto-transplant at our institution over the last 11 years and 3 months, and then short and long-term outcomes of these transplanted patients. Finally, I will come to the conclusions. If there is time, I'll go for appreciations. So, as you are aware, since the mid-1990s, high-dose chemotherapy followed by auto-transplant has become the standard of care for patients with newly diagnosed multiple myeloma who are transplant eligible. Cryopreservation is routinely practiced in the setting of auto-transplant. The long-term outcome of multiple myeloma subjected to auto-transplant has improved over the last 3 decades due to the progresses in patients' care. I found actually one excellent long-term outcome on multiple myeloma. Nishimura et al. Reported the long-term outcome of a total of 4,300 and almost 30 patients with newly diagnosed multiple myeloma treated with autologous transplant at the University of Arkansas in USA between the years 1989 and 2014. Of course, they were using cryopreserved stem cells. In that study, the 5-year overall survival was 47 to 70%, and the progression-free survival was ranging between 29 and 68%. This is the progression-free survival, where you see the 5 years, in the year 1989 was 29 and going to much higher to 68% in 2014. This is actually the graph A represents the overall survival of these patients. So just to get you back to the situation where we had at King Fahd Specialist Hospital just before starting our transplant program. Possibly our colleagues working in Riyadh know that 20 to 25% of the recipients of transplant in Saudi Arabia come from the eastern province, so the demand that time was very high. Our institution became partially operational at the end of 2006, but plenty of the infrastructure was lacking. So with interest, we carefully read the experience of stem cell transplanters working at various cancer centers which lack cryopreservation facilities. And we found out that their arrangements for transplantation and even their results were almost the same. This was reflected by large studies and major reviews published. After making sure that performing auto-transplant without cryopreservation is safe and doable, we did actually validate the viability of stem cells from samples of apheresis taken for our patients who were sent that time to King Faisal Specialist Hospital. And we also validated CD34 enumeration. So these are important landmarks in the history of transplant without cryopreservation. Studies have shown that peripheral stem cells can be stored in the routine fridge at 4 degrees centigrade for 5 days without significant loss of viability. Thereafter, the viability decreases progressively by 10% each day. Milfalan, there's another issue, which is still the standard of care as a conditioning therapy for multiple myeloma, is cleared from the plasma within 1 hour and from the urine within 6 hours after IV administration. So the technique is of value in 2 scenarios in medical institutions like ours, in the process of establishing stem cell transplant but lacking cryopreservation. So these are the major advantages and disadvantages of non-cryopreserved stem cell transplantation. Without cryopreservation, actually, the advantage is mainly simplicity, and after that, this can allow transplant as outpatient, a reduction in cost, a reduction in time, prevention of DMSO toxicity, and no significant loss of viability, unlike in cryopreservation. The main disadvantages are plenty of coordination between various teams is needed and inability to store part of the apheresis if a rich yield is obtained. So even non-cryopreservation was, available at least in the preclinical studies since the year 1957. After that, even 3 major studies performed in the West showing that overnight storage of autologous stem cells compared to cryopreservation had no significant difference between the 2 groups regarding viability, neutrophil or platelet engraftment, safety, or even long-term outcome. Even they found the same findings that this reduces cost and processing time. So back to our institution. Day 0 of our transplant, as I mentioned, we had no cryopreservation facilities. There was 1 permanent consultant, 1 part-timer, and 1 locum consultant. No single nurse in the hospital with transplant experience, no irradiation of blood products, and our infrastructure was being built. So just coming directly to the main findings, over the last 11 years and 3 months, we did perform 135 auto-transplant procedures for 119 patients. Well, the rest, 12 patients had planned tandem auto-transplants, and 4 others received second auto-transplant after relapse and progression, of course, after controlling their disease progression. The median age of our patients was 51.5 years, almost 15 years younger than that in the West. At presentation, our transplanted patients had significant, high-risk features. The revised international staging index, stage 3, extensive bone involvement, and adverse cytogenetics. As well, we had less than 10% having significant renal dysfunction or even end-stage renal failure. Over this time, we managed to transplant almost 79% without cryopreservation and 22 with cryopreservation. Almost 47% of our transplants were performed in the outpatient setting, while 53 were performed as inpatient. So, alhamdulillah, despite all the difficulties, the 100-day survival for our patients transplanted as inpatient or outpatient was 100%. And this is actually reflects the great care displayed by our medical and nursing staff. The 4-year overall survival and progression-free survival for patients with multiple myeloma who received fresh cells were 82 and 68 respectively. And we think that this is one of the best world figures. Alhamdulillah. Okay, so regarding the stages, almost 47% of our patients were stage 2 and 3. Cytogenetics, more than 40%, they had adverse cytogenetics, chromosome 3, 17p deletion, translocations involving chromosome 14 apart from translocation 614, which implies good prognosis and monosomies. Unfortunately, we had most of our patients having extensive bone involvement with lytic lesions, pathological fractures, osteopenia. Well, we had 6 patients with end-stage renal failure on dialysis, 4 patients not on dialysis yet, and we had 8 others with creatinine clearance ranging between 20 and 30. So the regimens used, well, mainly Velcade-based therapy, and well, initially we used Velcade-Dixa alone, like possibly most of the institutions. Then we moved to the triplet regimens, and VRD is still the backbone of our treatment. Number of lines given, well, alhamdulillah, almost 3/4 had only 1 line. More than 3 lines, less than 10%. Type of response achieved before auto-transplant, 60%, they had very good partial response, and less than 1/3 of patients had complete response. The stringent complete response was achieved only 1.5%. Regarding maintenance therapy, well, like other institutions, initially we were using thalidomide alone for 1 year, then 2 years, then Velcade came. Then after almost 2015, we started giving maintenance till disease progression for standard risk Revlimid and for high risk Velcade. So more than 50% of our patients have used this continuous progressive therapy. Regarding neutrophilic engraftment, as you know, we give G-CSF on day 5. The median day of engraftment was day 11, for platelets, day 17. The main complications encountered in the early pre-transplant period were mucositis engraftment syndrome in 1/4 of our patients and febrile neutropenias. Well, engraftment syndrome, I just like to elaborate here. Manifestations like those of acute GVHD, but milder. Main risk factors, heavily pretreated patients, second autograft, and high stem cell dose. However, we encountered 2 severe forms that needed a short cycle of steroids. And one of them, the second one, had capillary leak syndrome after ruling out cardiac and lung issues, and he was about to go to ICU. Only after giving him steroids, things were reversed. Outpatient auto-transplant, I'll just elaborate a little bit on that. Since August 2016, we've done 63 transplant in the outpatient setting. Also, we do at our institution auto-transplant in the outpatient for Hodgkin disease. We've done 32 so far. Main inclusion criteria are actually presence of caregiver who can bring the patient to hospital at any time, living nearby within maximally 30 minutes from hospital. Candidates actually for auto-transplant are treated the same way, with the difference that they have to come daily to the treatment area to have their labs and to have clinical evaluation. we encourage the caregivers to bring them to ER in case they notice any complications, and our on-call physicians are instructed to admit these patients whenever they have complications. By the way, 25% of our patients get admitted for a day or two because of mucositis and possibly fever. So for patients with renal dysfunction, as I elaborated, the numbers, well, the main differences, number one, to modify the doses of medications according to creatinine clearance, administering chemotherapy after hemodialysis, and including milfalan. The doses of milfalan we used were ranging between 140 to 200 milligram per meter square. And one important thing is to give the stem cells after dialysis, otherwise you may lose them. This is actually our long-term data. This is the overall survival for the entire group. The 5 years is almost 75%, and the progression-free survival is in the region of 60%. And see here, one important thing is that, well, even at 11 years, the overall survival is still around 60%. Here, possibly, this is the most important slide for us, just to show you for fresh cells, the patients who received their autografts without cryopreservation. See, the 4-year overall survival is 82%, mashallah, and the progression-free survival 68. And see the same pattern. Possibly if they exceed 10 years, they may die of other medical causes. A progression-free survival for inpatients compared to outpatient, well, initially the curves will overlap, then they diverge, but the difference between the two is not statistically different. For overall survival, the curves diverge early, but still the difference is not statistically significant. Here, yesterday we heard a lot about role of maintenance till progression using multiple agents and continuous therapy. Just here, we are not hiding our data, number one. Number two, we like our colleagues working at other institutions to look into their data. We've seen a disappointing result after applying this, maintenance therapy till disease progression and continuous therapy. See here the difference. Those transplanted before 2015, their overall survival and progression-free survival were 66 and 60%, while those transplanted after, this is progression-free survival, the 5 years and 8 years, and those transplanted after 2016, the percentages dropped to 51 and 45 respectively. Overall survival as well, there is a significant difference there. See, the picture becomes much clearer if you compare those transplanted before 2017 compared to those transplanted after that, and see the progression-free survival dropped from 65 to 46%, and the overall survival dropped significantly from 76 to 45% with highly significant p-value. So with my respect to everything, we have to examine our own data. Okay, examples of outstanding cases we treated and we reported at our institution. In 2011, we had a young patient with multiple myeloma, refractory to 4 lines, then responded to 5th line. As he had end-stage renal failure, we offered him a renal allograft. He's still alive. In 2012, a year later, same story, end-stage renal failure, but insulin-dependent diabetes. The important thing is that after day 100, the patient needed 0 unit of insulin. Till now, over 10 years, his insulin dependent diabetes has been cured with autotransplant. Another one, 2016, plasma cell leukemia cured with tandem transplant followed by autotransplant. This is no time for a difficult case who failed even allogeneic transplant and tandem transplant. In conclusion, so autologous transplant without cryopreservation is safe, feasible, and leads not only to excellent short-term outcomes, but also to long-term outcomes that are comparable to the standard autologous transplantation with cryopreservation. So for us, even after having cryopreservation facilities installed at our institution about 10 years ago, the excellent outcomes encountered encouraged us to continue offering at least the first transplant in myeloma with fresh cells. Fresh cells as well allowed us to perform almost 47% of our stem cell transplantation as outpatients, thus reducing costs and saving beds. Multiple myeloma with in patients with end-stage renal failure should not be excluded. Particular attention should be paid to dose adjustment and the timing of administering stem cells. This is first transplant. This is the celebration we had. This is the short stay outpatient transplant. These are our consultants, coordinators, nursing, and we thank everybody who has been involved in this great work. Thank you very much.
Dr. Khalid, the talk was so impressive that I couldn't stop you even after you had exceeded the time 1 or 2 minutes. I have a few questions.
Yes.
Your outpatient transplant rates are very impressive. Do you offer housing to the patients yourself?
Yes, we offer housing, yes, for the patient and the caregiver.
And what is your neutropenic fever admission rates,
Yes, as I mentioned in one of the slides, 25% they get admitted for a day or two maximally.
Okay.
But this does not delay engraftment, does not delay anything, actually, yes.
So majority, 75% of people you are
75 do not
managing
need admission at all.
And so that means they don't get fever at all?
Yes, yes.
Very impressive, alhamdulillah. One last question. You know, the progression-free survival and overall survival after 2016 showed the PFS and the OS after 2016 seem to have gone down. What do you think is the reason?
Very interesting question. Actually, we did these graphs and we added the last 15 months, just 2 weeks before coming. Although I was noticing together with other colleagues that, you know, we are not doing as good as before. Regarding therapy-related complications, we had one who developed acute leukemia out of these. We had several admissions with, as we are giving more intensive treatment, febrile neutropenias. We had few deaths, but they do not account for this. I guess, you know, are we over-treating? This is number one. Giving continuous therapy with medications like lenalidomide, for instance, you know, as the situation in patients with 5q-, if you treat for a longer time, you make the quiescent mutation active. Is this the same situation with this drug and with others? We are asking for more mutations and more clones to evolve. So possibly this is the explanation. We are examining our data. We are asking our colleagues to examine their data as well. Yes, please.
But did you look into the patient cohorts, both characteristic of the...
Sorry?
Did you look into the patient characteristics in the two cohorts? Maybe
yes.
The reason is in there.
Yes, yes. Actually, looking into the two cohorts, whether there is any difference in staging or cytogenetics or response to treatment, we found no difference. This was easy for us to figure out. So the same pattern. We are not, you know, having any new. Actually, with the you know, initially we didn't have many medications. We didn't have the luxury of having, you know, daratumumab, pomalidomide, and others, and yet our outcome was still superior. This is the thing. You know, here I guess there is a balance. not all our patients are high risk, so we have to give possibly continuous therapy, maintenance therapy to those who are in need. Risk stratification is important. Not one size fits all. I guess you have to differentiate between somebody with standard risk and somebody with aggressive disease. Plan of treatment should be totally different. But we have to look into our data again and again. Thank you.
Any more questions from the audience? Because Dr. Khalid has to leave after this talk.
I believe that congratulations for your data about myeloma.
Thank you.
And I believe that for Hodgkin lymphoma, you were doing it before because you are lacking of cryopreservation facilities. But now, after you have cryo facility, are you still doing Hodgkin with melphalan alone?
No, not all patients with Hodgkin. So only those who respond well and who have negative PET before transplant. We offer them, and not those who are heavily treated. So there are particular criteria to give melphalan because I guess the Canadians were the first to describe that melphalan for at least patients with multiple myeloma or with Hodgkin lymphoma is as good as Beam. Yes.
Quick question, Dr. Khalid.
Yes,
Thank you very
please.
much. Excellent presentation. So for patients who are undergoing an outpatient transplant, do you bring them on the weekend to check their counts?
Yes.
On the weekend?
Yes, yes. Our treatment area works even over the weekend. And we even transplanted patients in the old era over the weekend. Even now, sometimes, with line insertion, administration of melphalan, family situation, we have to take all these into consideration. So we transplant even over the weekend.
Excellent.
Thank you very much. Thank you. Any
Thank
other
you very much,
questions?
Dr. Khalid.
Okay.
I think
معلش يا جماعة, I have to make check out and leave. Okay, thank you very much. Grateful
Thank you
to
very much. Excellent. So it's my pleasure to welcome the second speaker, my colleague, Dr. Amjad Al-Thubaiti, who is a chief fellow in our center at King Abdulaziz Medical City, Jeddah. She will talk to us in the next 20 minutes about the toxicity analysis of brentuximab AVD in patient with advanced stage Hodgkin lymphoma single center experience. The floor is yours, Dr. Amjad.
Okay,
please go.
Thank you, Dr. Salim, for the nice introduction. Today, it's my pleasure to present to you our data about toxicity analysis of our center experience about brentuximab AVD as a first-line therapy in advanced stage classical Hodgkin lymphoma. As in introduction, in 1975, the most commonly used frontline regimen, which is the ABVD, has not been modified since that time. Outcome for patients with advanced stage Hodgkin lymphoma have improved dramatically over the past half century. And as we all know, up to 30% of patients with stage 3 or 4 Hodgkin lymphoma harbor refractory disease or relapse after frontline treatment with ABVD. And as we all know, bleomycin is associated with unpredictable and even fatal pulmonary toxicity. For that, we have the brentuximab vedotin, which is an antibody-drug conjugate composed of an anti-CD30 monoclonal antibody conjugated by protease cleavable linker to the microtubule disrupting agent, which is monomethyl orostatin E. Actually, this drug at the beginning approved for relapse and refractory Hodgkin lymphoma, and then approved post-transplant as a consolidation therapy in patients with high risk for relapse or progression by the ATHERA trial. Until we have the Echelon-1 trial, which is published in 2018 in the New England Journal of Medicine, that approved brentuximab vedotin for stage 3 and 4 Hodgkin lymphoma in frontline setting. Echelon-1, as we all know, is a large international open-label randomized multi-center phase 3 trial was conducted to compare the brentuximab AVD to the standard of care in frontline therapy in patients with stage 3 or 4 classical Hodgkin lymphoma. The primary endpoint was modified progression-free survival, defined as time to disease progression, death, or modified progression, that defined as evidence of non-complete response after completion of frontline therapy according to review by independent committee, followed by subsequent anti-cancer therapy. The secondary endpoint was overall survival. The demographic data of the echelon 1, it was the male represent about 57% of the patient, and the age group, they categorize the patient based on the age. Less than 45, they represent most of the patients, 68%, and the elderly 65 and above were only 9%. Then according to the Ann Arbor stage, at initial diagnosis, stage 4 represent the majority of the patients, 64%, and the presence of the B symptom. The result was the median follow-up of 24.6 months, which is the 2-year modified progression-free survival. In favor of the brontuximab AVD-R, the result came back 82.1% compared to the ABVD 77.2%. And you can see yesterday that the 5 years follow-up also that released recently, also in favor of the brontuximab AVD arm regarding the 5 years follow-up for progression-free survival. The modified progression-free survival as assessed by independent review committee was also in favor of brontuximab AVD. Disease progression were 90%, where 90 were in ABVD 102. Death from any cause also was less, and subsequent anti-cancer therapy less in brontuximab arm, 9 compared to 22 in ABVD. In cost of the progression-free survival, we have to look to the safety and toxicity from this medication. So we found that according to the adverse event resulting to drug discontinuation that will affect the overall survival and death during treatment and hospitalized rate. And the common adverse event that we noticed mainly as the echelon 1 is mainly neutropenia, peripheral sensory neuropathy, and abdominal pain, and also vomiting and constipation in some percentage. So in our experience, it's actually we have been implanting a brontuximab AVD protocol in our center since 2018 in advanced classical Hodgkin lymphoma and Arbor stage 3 and 4, either as a frontline or if the patients did not tolerate the ABVD due to lung toxicity. Actually, we did a retrospective cohort study to assess the relationship of patients' characteristic and the number of cycles received, dose delays, reduction, common adverse event, number of ER, and hospital admission and ICU admission from toxicity as well. The data source was electronic files at National Guard Hospital Jeddah from 2018 to 2021. We found a total of 37 patients with advanced stage assigned to receive brontuximab AVD, which is doxorubicin, vinblastine, and dacarbazine. All we give them filgrastim support as a GCSF primary prophylaxis. In our analysis, we found that the male represent the majority of the patient, would represent 73% of our data, and the female 27%. And compared to the echelon 1, also the male was higher to the female, but it's not that the difference as in male. The majority in our data is mainly for the represent male gender. Regarding the age group, as the echelon 1, most of the patients were young, less than 45%, represent 73% of the data, and the more than 65%, more than 65 years, only represent 3%. The stage of the disease, most of the patients were 65 of them in stage 4, 19% in stage 3, and 16% in stage 2 with unfavorable features, either bulky disease or the presence of the B symptoms. Regarding the B symptoms, 92 from the patients, they have B symptoms. And 3% they have bulky disease, and 5% without B symptoms. Actually, we add smoking here. We compare. We try to see the smoking as a baseline characteristic demographic data, and we add also the diabetes, and we add the BMI, which is not was in the main trial. And we found that 45.9% smoker and 54.1% non-smoker. And more than 30, the BMI more than 30 represents 16.2, and less than 30 represent the majority of the patient, 83.8%. Then we try to look to the ER visit. The ER, most of the patient, 46%, they didn't visit the ER. Then 22% they visit the ER 4 times, and 14% they visit the ER 2 times, 11% 3 times, and 8% visit the ER 1 time. But so the majority, they didn't visit the ER, which represents 46% of our data. When we look to the reason of the ER visit in order to correlate with the toxicity, we found that most of the patients, 56%, they visit to the ER to do other causes other than febrile neutropenia, small pain, abdominal pain, which is mainly chest infection, pneumonia, and constipation, and vomiting, and chest pain. And so one patient, they have GI bleeding. The other patient, the fibrinotripenia, represent 19%, and the bone pain from mainly filgrastim represent 11%. Actually, because most of the patients that received the brontuximab in frontline setting, they came to the ER in abdominal pain. When we just looked to the abdominal pain, we found it represent from the 37 patients, 14% came to the ER due to abdominal pain. And when they did the investigation, they found only one patient they have bowel ischemia. The other patient we didn't find the cause of the underlying abdominal pain that they have. Regarding the hospital admission, from this 37 patients that we collected, 65% admission rate, and 10% from those 65 admitted into the ICU, mainly due to infections and after fibrinotripenia, as a subsequent to fibrinotripenia. Mainly our analysis to focus about the toxicity and the safety. So the therapy toxicity, as you can see, neutropenia, grade 3 and 4, represent 73%. And regarding the febrile neutropenia, represent 35%. And we found also the abdominal pain represent 32%. The diarrhea, 16.2%. Pyrexia without neutropenia, it represents 43%. The fatigue, grade 2 or more, it was 29%. Vomiting, 13.5%. Constipation, it was about 29%. When we compare it to the data from Echelon 1, we found regarding our result in the orange column, neutropenia was higher, 73, and also abdominal pain was higher, febrile neutropenia higher, peripheral sensory neuropathy is very high. We represent in our data 54 have febrile neutropenia, where in Echelon 1, only 5%. The diarrhea, 16%, and the fatigue almost the same. Constipation is less than the trial. The pyrexia without neutropenia, it was 43%. And the vomiting is less than the trial. It was represent only 13%. So mainly neutropenia and febrile neutropenia, abdominal pain, and peripheral sensory neuropathy. Regarding those side effects that may either febrile neutropenia or mainly febrile neutropenia or ER visit or mainly hospital admission due to febrile neutropenia will lead us to dose modification, either delays or reduction. So when we compare it to the main trial, we found in our data that we delay the dose in 27%, while in the main trial, they delay the dose in 48% due to side effect. The dose reduction is almost the same. In our data, we modify the dose either to mainly to the side effect in 24% for the patient. And as we all know, that will affect in a negative way regarding the overall survival and the disease-free survival. When we look in the literature to find that the relationship between chemotherapy dose intensity and dose density compared to the overall survival and progression-free survival, we couldn't find anything for the Hodgkin lymphoma. This graph from the data that published for non-Hodgkin lymphoma mainly, but we can elaborate that if the patient receives full dose, he will do better regarding the overall survival. But when you modify the dose to the moderate or low, that will correlate in a negative way with the overall and disease-free survival. The primary resistant in our data was 13.5% in those patients who they didn't complete their therapy, either due to dose reduction or dose modification. While in Echelon 1, it was 7%. So the result that we concluded from those small number of patients, we found just a weak correlation between the age and each of dose reduction and dose delay. Age and dose reduction, the correlation was only 0.25. Well, that's not significant. Age and dose delayed 0.23, and there was a weak negative correlation between the number of cycles and febrile neutropenia. Actually, it's published in the main Echelon 1 that the number of the febrile neutropenia happens in the earlier of the cycles compared to the later cycle. While in our data, we found it's mainly after cycle 4 and cycle 6. That could give us an idea that it may correlate to the treatment, not mainly to the disease. But actually, we need to increase the sample size. Number of cycles received and febrile neutropenia correlation, it was minus 0.37. So we performed a logistic regression to assess the association between the patient's characteristic and the therapy toxicity by controlling our baseline characteristic, which are age, gender, smoking, diabetes, BMI, stage of the disease, and number of cycles. Sorry. How we can go to the next slide? Actually, we found that we found a negative a negative correlation, so we need further to increase our sample size. So our next step to enroll more patients, and we need long-term follow-up in order to determine the progression-free survival and overall survival. And also our next step to compare with the ABVD arm that used in advanced stage classical Hodgkin lymphoma in terms of toxicity, dose modification, and ER visit at the same time that we implanting the brontuximab in frontline setting, which is from 2018 till the last year, mainly to 2020. Thank you.
Thank you, Dr. Amjad, for this excellent talk. I think we'll leave the question to the end.
Okay.
And
so I'll now welcome Dr. Ahmed Hijazi. He's an associate consultant in Princess Noor Oncology Center. So we have teammates presenting back to back. Inshallah, this will be an exciting session as well. So Dr. Hijazi completed his membership of the Royal College of Physicians of Ireland in 2011 and 12, and he completed the Saudi residency program in internal medicine. In 2013, he completed the Arab board program in internal medicine. The hematology fellowship was in 2018, and he's now working as an associate consultant. So welcome, and we are looking forward to this exciting talk.
Okay, thank you, Dr. Benyamin, for presenting me. Firstly, I would like to thank the organizing committee for giving me this chance to present in this distinguished meeting. And my talk today will be about AML. This is a single center experience at the Princess Noor Oncology Center in King Abdulaziz Medical City in Jeddah. So in our study, we had a retrospective analysis of demographics, clinical characteristics, toxicities, and treatment outcome for adult patients with acute myeloid leukemia since 2000. Firstly, I will go shortly through some epidemiological data about acute myeloid leukemia. So there was around 60,000 new cases of leukemia in the United States in 2018, and that constituted around 3.4% of all cancers. Acute myeloid leukemia accounted for around 32% of all the new leukemia, with estimated death of 10,000 cases yearly. So AML is a disease of adults, so it accounts for around 80% of acute leukemia in adults, with some male predominance. And it was published in multiple studies that AML is a disease of elderly with a median age of 65 years at the time of the diagnosis, although we have some heterogeneous data as what was reported here locally in Saudi Arabia, and I will talk about that later in my presentation. So in Saudi Arabia and worldwide, there has been an evidence of increasing incidence of leukemia over the past 15 years, and that actually had a huge impact on the general population health as well as the health institutions. So next, I will present a few data from the Saudi Cancer Registry in 2016. And as we can see here, that leukemia ranked the 5th among the most common cancers in Saudi Arabia, while it was the 4th among male and the 6th among females. Looking here into the chart, which is comparing the age standardized rate for leukemia among Saudis and other nationals, as you can see here that the rate of the leukemia was 3.6 per 100,000 among male, and it was 3 per 100,000 among females. Coming here to the adult group, so we can see here that leukemia occupied the 9th among the most common cancers. And if we looked into the most common leukemia in Saudi nationals, acute myeloid leukemia ranked the 2nd one. And here we are talking about both pediatric and adult groups. This symbol curve is showing us the increasing incidence of leukemia as overall with age advancing. But if we are talking about acute myeloid leukemia, the median age at diagnosis among adults in Saudi Arabia was lower than other Western countries, and that has been demonstrated in different studies local in Saudi Arabia. So our colleague in National Guard Hospital in Riyadh, they showed that the median age at diagnosis was around 52 years, And we had also another study from King Abdullah Medical City in Mecca, where the median age of diagnosis was around 42 years. We have actually a similar data in our study. So, as we know that there are many factors contribute to the AML treatment outcome. We know that elderly AML population, they do actually poor in general. And that has been attributed actually to multiple factors, including the poor performance status, the presence of multiple comorbidities, and the accumulation of different genetic mutations. These results actually has been revealed in multiple studies, either internationally or locally. So as we can see here, this is a paper which was published in British Journal of Hematology about the outcome of acute myeloid leukemia in England over 3 decades. And we can see here clearly that there has been an improvement in the outcome of AML among the young and middle age group, while the elderly population continued to have a poor outcome. We had also a similar data locally here in Saudi Arabia by our colleagues in National Guard Hospital in Riyadh, and we can see here the differences in the outcome among different age groups. Again, the impact of age on the AML outcome has been demonstrated across different ELN risk stratifications. The second most powerful tool in the prognosis of acute myeloid leukemia is the cytogenetics and molecular features. And everyone actually is familiar with this table, which is the 2017 ELN classification that has been established after analyzing the impact of different cytogenetic and molecular mutations on the outcome of acute myeloid leukemia. As we can see here clearly, the outcome among different risk groups. Also, we have some similar result locally in Saudi Arabia by Dr. Amal Abdul Wahab and her colleagues in King Abdullah Medical City, and the result it's comparable to the international one. Next, I will come into our study. So in our study, we present analysis for retrospective data of 190 patients with a non-ABL acute myeloid leukemia who were diagnosed or referred to Bernsis Neuro-Oncology Center between 2000 and 2020. Here we can see we had a total number of 190 patients. 22% of our patients were eliminated from the analysis because they underwent a palliative treatment, so we ended up analyzing around 149 patients. So if we come next to the patient or the clinical characteristics of our patient, we can see here that females constituted around 52% of our cohort, and the male constituted 48%. Coming to the age group, we can see clearly here that most of our patients were at young and middle age group between 14 and 60 years, while only we had 9% of our patients with the age group above 60. That actually gave us a median age of 45 at the time of diagnosis of acute myeloid leukemia, and that actually concurred with the other local studies. So this age group had reflected also the number of the comorbidities. So as we can see here, we have around 97% of our patients, they had no or one comorbidity, while only 3% with 2 or more comorbidities. So this is the white blood count at diagnosis, and we can see here that most of our patients were presented with a leukocyte count of less than 50,000, and the others are distributed in the chart. So looking into the cytogenetics distribution in our cohort, we can see here that we had 40% of our patients who were presented with normal cytogenetics. In version 16, we had 8%, and we had 10% of our cohort with translocation 8 and 21. And also we had 6% with trisomy 8, And with regard complex cytogenetics, including monosomin 7, the percentage was around 16%. It's worth actually to mention here that internationally, the reported prevalence of complex cytogenetics in AML patient is around 10 to 12%. So we concluded actually that we might have a trend toward a higher prevalence of complex cytogenetics among our population. Next, we looked into the distribution of the patient as per the 2017 ALN risk certification, and we can see here clearly that we had 31% of our patients who fell under the favorable risk group, while we have 27% under intermediate risk group and 35% in the adverse risk group. Coming now to the result. So firstly, we looked into the end of induction outcome. So we saw that, we observed that complete remission, CR or CRI, has been achieved in around 69% of our patients, while 25% of our patients were refractory, and we had 6% death in induction. And when we looked into the impact of the ALN risk certification on the outcome after the induction, it showed the superiority of the favorable risk groups over the other groups. So the CR rate among favorable risk groups was around 95%, while among intermediate risk group it was 67%, and those patients in the adverse risk group, they had the worst end of induction outcome with 49% only. Now we will look into the overall survival and the leukemia-free survival. So in the whole cohort, the overall survival was 20 months, while our leukemia-free survival, the median leukemia-free survival was 13 months. Then we went through a subgroup analysis. So considering the age group, it's clearly seen here the differences between the outcome in the overall survival among different age groups, and that was statistically significant. Again, the outcome in the leukemia-free survival was statistically significant among different age groups. Next, we looked into the result as per the ALN risk certification, and we can see clearly here the differences between the differences in the outcome between different risk certification groups. So the median overall survival among favorable was not reached, and we had a mean overall survival of 132 months, while those patients with intermediate risk group, we had a median overall survival of 22 months, and the worst was among patients with adverse risk group with only 10 months. The same thing was demonstrated with regard to leukemia-free survival. So the median leukemia-free survival among favorable risk group was not reached, and the mean duration was 134 months, while the median leukemia-free survival for the intermediate risk group was 14 months, and for the adverse it was 8 months. And that was statistically significant. Then we looked into the result of based on the different cytogenetics at diagnosis. And as you can see here, that the best result was with population with inversion 16. So the median overall survival was not reached, and they have a mean of 157 months as a mean overall survival, while those patients with normal cytogenetics, they had a median overall survival of 54 months. And surprisingly, we found that patients with translocation 821, they did poor in our study with a median overall survival of 20 months. And the worst outcome, as usual, was with people with complex cytogenetics with a median overall survival of 5 months. The same thing was revealed in the leukemia-free survival. So the best result was with the inversion 16 with mean leukemia-free survival of 155 months, while patients with normal cytogenetics, they had a median of leukemia-free survival of 47 months. And again, translocation A21, they had a poor outcome with regard to leukemia-free survival with a median of 13 months. Coming to the impact of white blood count on the outcome, so we can see clearly here that there has been no difference in the outcome, either in the overall or leukemia-free survival, based on the leukocyte count among our cohort. And I think that that was due to easy accessibility to some facilities like leuko reduction in our institution. Also, the early initiation of the chemotherapy contributed to a similar result. Again, we looked into the patient with either presence of or absence of extramedullary disease, and again, we found that there has been no difference in the outcome among those two populations. Finally, as we saw that most of our data actually are comparable to the internationally mentioned data with regard to the outcome of acute myeloid leukemia, considering the age and the cytogenetic and the ELN risk stratification. But the only discrepancy we found is among patients with the translocation with A21. So I've just mentioned here a few more data about our patient with the translocation A21. So we had a 14 patient in this subgroup who were treated in our center. Complete remission was achieved in all of them. Relapse rate we have among those patients was 57%, and 37.5 among the relapsed patients, they were salvageable. One patient remained alive after salvage chemotherapy alone, while one had a non-relapsed death post-allogenic stem cell transplant, and the third had died due to disease relapse. We had 5 patients who underwent allogenic stem cell transplant. 4 of them were in CR1, and 1 of them in CR2 only. So in conclusion, median age at diagnosis of AML in our center and concur with the other data which was mentioned in Saudi Arabia is lower than other countries. Also, we have seen that the age and the genetic mutations have the most impact on AML treatment outcome. I would say that there is some trend toward a higher prevalence of AML with complex cytogenetics in comparison to the reported data internationally. Acute myeloid leukemia is a heterogeneous disease, and that might cause a variability in the outcome among different populations. And we have observed that in our patient with translocation A21, where they had an inferior outcome in comparison to their reported data in other studies. Also, incorporations of newer medications has led to a better outcome in different studies, and we'll be awaiting for our local data in Saudi Arabia. By that slide, I conclude my talk. Thank you very much, and I'll be happy answering your questions.
Thank you, Dr. Ahmed, for this excellent presentation. I would like to ask Dr. Amjad to join us in the podium for the Q&A session. And if there is any question from the audience, please to Dr. Ahmed Hijazi and Dr. Amjad Thibeti. I think Dr. Ahmed Saeed have a question, please.
Thank you, Amjad, and thank you, Ahmed. Excellent presentations. You showed that toxicity is higher in our cohort than in the Echelon trial. you showed the toxicity is higher, but the dose modification and delay is lower in our cohort. Is that true? So what would be the explanation? Because logically, if you have more toxicity, you might go for.
Actually, the toxicity mainly wasn't lead to dose reduction, because mainly it was for like grade 2 and less febrile neutropenia and abdominal pain, peripheral neuropathy. And also the febrile neutropenia, it's mainly the cause for dose modification. But the others and we didn't modify the dose unless grade 3 and more, peripheral neuropathy mainly. But for the abdominal pain, it wasn't that significant that we need to modify our dose. I think also we have, because of the sample size, only 37 patients, the correlations wasn't that great. So we need to increase the sample size, and we look again to our data. Because it only represent, the sample size in echelon 1, it was 665. Our sample size is only 37 patients, so it represents only 5% of the data. So in order to compare, it's unfair. Just we are showing here just to give us prelim result only, but this is not statistically the right way to do it.
Dr. Amjad, as a follow-up question, I noted that your slide said the echelon 1 peripheral neuropathy versus your peripheral neuropathy was hugely different. It was 54% in your data and like less than 10% for the echelon data. Do you know if the same measures were used to calculate the peripheral neuropathy, or how can you explain that?
It's the same reason that I told Dr. Said about it. I blame the sample size, because only 37 patients. In echelon 1 is 665 patients. So the correlation is not statistically the right thing to do. Just we are compare it to give us an idea that we have to match at least the same sample size. We have, or we have to calculate the weighted sample size, but we didn't do that. So inshallah, next step we will calculate at least the weighted sample size in order to be the comparison to be fair.
Yeah, and Dr. Ahmed, again, thank you. It's just a comment more than a question regarding 821. So your data also is comparable to the local data that 821, they don't do as good as what is mentioned elsewhere. You mentioned that all of them, they achieve CR, so it's easy for them to go to CR, but the issue is with the relapse. And this, again, bring that we should now look into how to improve their outcome by, for example, changing the treatment for them by, for example, adding Mylotarg to the treatment of core binding factors.
Actually, I think also I think that the incorporations of the new modalities with regard to the monitoring of the disease, the MRD of the disease by molecular result, would have an impact also in our outcome. So the post-remission therapy I think it might be changed based on the MRD evaluation among those patients.
Any other question from the audience? Dr. Haraska?
Can I? Yes. Yeah, thank you. Both talks were great, and it's good to have, to explore these local experiences. My question to Amjad regarding your, you mentioned, you brought up safety data, which is side effects and others. I did not see much of efficacy data except the resistance you mentioned, and I wasn't sure what do you mean by the resistance.
The PET scan at the end of treatment.
Repeated?
The PET scan at the end of the treatment was showing DVOL5 refractory disease. Either DVOL5 or, there is 2 patients actually transformed to another lymphoma. One patient like a diffuse large B-cell rich, T-cell rich diffuse large B-cell lymphoma, and other patient as angioimmunoblastic. When we repeat the end of treatment bit, it was positive DVOL5, and we repeat the biopsy, it was different pathology. This is in 2 patients only. The others, it's mainly the same disease.
So isn't that CR rate? You would call it CR rate,
yeah.
Right?
Okay. But actually, this mainly for the toxicity and the safety, not for the efficacy. We didn't. We need long follow-up because most of the patients they didn't finish yet their treatment.
Okay. So you focus. Your objective was to assess the safety.
Yeah.
Why not to assess the CR rate at the same time?
This is our next step. And this is our another. We are in the early phases of the trial of the studies. Our next step, we're gonna assess the efficacy, and also we compare it to the standard of care, which is ABVD.
Another question. Well, I mean, I know you mentioned at the beginning how you selected these patients advanced stage and those who would not or expected not to tolerate bleomycin and others, right?
Yeah. You mean brontuximab vedotin?
Yeah. I mean, were they like a homogeneous group, or you selected? How did you select these patients?
Okay. It's according to the lymphoma tumor board, according to the primary physician. And if the patient has, like he has a smoking history and he has underlying lung disease, they will go with brontuximab more safer than the bleomycin. Maybe
so actually, the triggering point was there was no consensus how to use brentuximab in front line, so it was left to the MRP discrete. And most of them, they were all advanced stage and they have poor risk factors. But the trigger to look for this safety and efficacy, because we observed ER visits, pneumonia, even ICU, so we started to look into this. And this will be like a background of even trying to make a consensus of using brentuximab as a front line in our cohort.
Dr. Absi?
Yeah, just one comment about the issue of toxicities. Obviously, this is all subjectively evaluated retrospectively. So I agree that this is a weakness. We did not, at least from a grading point of view, I would say. That's on one hand. On the other hand, I think the answer to the question of Dr. Saeed, why don't we dose reduce? I think in general, because patients treated on clinical trials, there are clearer guidelines when it comes to grading of toxicities and what reflexes do you take in terms of dose reductions of modifications. That's not the case in clinical practice. In practice, many of the times, those patients are seen maybe by not the same person who saw them the last time. They may not be seen by the MRP each time they come for chemotherapy. And we know that. We know that those modifications in real life setting is not necessarily done similar to what they are done on clinical trials. This could explain why those patients subsequently came again to the ER, or they were admitted subsequently, that maybe the doses we needed to be reduced or modified. Probably, we don't know. And then the other thing is that you see that there's a discrepancy between the ER visits and the admissions. The admissions actually were sometimes done directly from the clinic without the patient actually visiting the ER. So sometimes there's an ER visit that did not result in an admission, and sometimes is the other way around. I think what's frightening in our data was the admission rate. ER visits could represent some weakness in the outpatient setting, where some of those patients could have been managed in the outpatient and didn't need to come to the ER. But I think the admission rate was strikingly very high, leading to those delays rather than quote-unquote modification, and sometimes interruption of therapy, and then we come to the issue of efficacy. The problem is that the median follow-up is so short, and some of those patients are still on therapy. It's really meaningless to look into the lymphoma-free survival. And we thought that the only caveat, if you want, or an indices to the subsequent result would be primary resistant disease. At the end of the day, they are advanced stage, like what the echelon data showed. And we thought that 13% primary resistant disease is pretty high to disease that is being treated with up-to-date therapy like this. So the next step will be a group of patients who were treated with ABVD during the same time period, because their MRP choose to give them ABVD. And we want to match these two groups together and look at them at the end of the day.
Okay.
That's it.
Thank you. Any other question from the audience? I have a question, Dr. Hijazi. What's the percentage of your patient, they had a molecular abnormality study at baseline, and how did that, did you analyze the effect of the molecular abnormalities at baseline? And what's the percentage of those patients who were tested for molecular abnormalities?
You mean among patients with translocation 21 or
No,
in general?
all NPM1, FLT3, CKIT, all the molecular abnormalities, were they tested, and what's the percentage, and did you analyze their effect on the outcome?
Yeah, actually, so today, actually, I just presented the initial data, or initial result of our analysis, and further we will do some other subgroup analysis just to look into the rate of molecular remission and how did that impact on the outcome. So this is an area which we will look into later, inshallah.
Okay.
Do you know if, as a follow-up, do you know if CKIT was looked at? Because there was a local Saudi data about the 821 and CKIT being, high risk. Do you know if your 821s were associated with CKIT?
Yeah, actually, we have some of our patients with 821 who had a CKIT mutation. I didn't wish actually to include them in the analysis result because they were removed from the 2017 ELN stratification. It was there in the old NCCN guidelines, but it's not there anymore in the ELN. So I disregard their effect actually, but also we may look into that in specific.
Okay.
Interestingly, the CKIT, the 821 data is so poor that I'm starting to think we should be transplanting all of them. It's like 20 months progression-free survival.
Yes, it was. Actually, I think that we have also to look into other characteristics, even apart of the CKIT. I think that our population is a bit different from the others. There might be some other cytogenetic abnormalities which might have an impact on the 821 result. Also, maybe some of them did not go into MRD negative status after the completion of their therapy, so that put them at a high risk of relapse.
Okay.
So further data and the further analysis actually in the future, we'll look into that.
Okay.
A question to Dr. Ahmed. Are you using Myelotag? Do you have easy access to Myelotag?
As non-formulary.
But you can get it.
Yeah, we are trying to get it, not used yet, but they use it in National Guard trial, 2-3 patients, and I think King Faisal in Jeddah, but we are hoping to have it soon.
Sure.
And we are incorporating it with our new proposal for core binding factors, AML.
Okay. Any question from the audience, or I'll have the last question? So just last question to Dr. Amjad. Did you have a chance to look at specifically, as Dr. Absi mentioned, the grading of the side effect, like grade 4 and 5 adverse event? Do you have a specific number in mind about grade 4 and 5 adverse events or severe adverse events?
Yeah, we have a chance to look, but actually because of due to, I think, poor documentation, some of these just wrote peripheral neuropathy without specify the grades. So this is the big barriers that I found in order to define which patient grade 2 and 3, and due to documentation barriers.
But there was no death in your cohort? No death, no grade 5 event?
No grade 5.
Okay. So
I think that comes to the end of the session. Thank you both speakers for delightful talks. And this is the end of the conference as well. So we'd like to thank all of you who have attended in person, and it was very fruitful. So thanks once again, and we'll meet again next year.